We're going on air now, so let's just wait for the participants to log in. And then once we log in, once we have the participants, maybe we can start in a few minutes.
And of course, Reservis in Argentina in 3 weeks' time. Rossi is on the charge. Ducati are after him. Marcus had a bad night, but he will be back big time. He has won for the last 2 times at Austin, which is the next round of the championship.
Allen.
Listen to the crowd.
Allen.
Hello, Ray.
Okay lang, sir. Nililista ko lang po yung mga guest natin.
Yeah. Asim is here. Hi, Asim.
Hi, how are you?
Hello.
Hi.
Hello, bro. Thank you so much.
Yeah, you need to thank me quite a lot.
I just texted Asim a few days ago.
Yeah.
Don't worry, Asim. You're all the same.
Yeah.
Because it's a weekly conference, everyone. So that's why.
Yulong, wow, you so Yulong, wow, you look so
Yeah.
handsome, man. When done, you
Yeah,
look good in a tie. Wow.
Yeah. Basim, how are you?
I'm good. How are you, sir?
I'm good. Yeah. How about the COVID in Singapore? It's okay now?
It's very good.
Good, great. You
Anyway,
can control
before
up.
we start,
Yeah.
Asim, please meet Professor Masanori Tokunaga from Japan.
Arigato.
Masanori Tokunaga.
Yes.
Also, please meet Professor Vudoy Long. Vudoy. Vudoy is from Ho Chi Minh, Vietnam.
Woody Leong is
Asim
the
is
best
from
man.
Singapore.
The best esophageal gastric surgeon.
Thank you.
So we're waiting for 2 more, Shannon and Sue from South Korea.
Yeah.
It's gonna be an interesting night. It's the last part of the gastric webinar series. Professor Abari is in. Hi, sir. Dr. Abari. Magandang gabi po.
Hi, Alan. Good evening, Alan. I'm here.
Hey, Shannon. Finally.
Sorry. I just finished an emergency operation just now.
Ray is here. How are you?
Hello, how are you? I'm super busy.
Sorry for pulling you out of the OT.
No, we just finished, just on time.
Are you in the clinic or in the office or in the OT?
I'm in the office.
Thank you for raising the invitation.
Thank you for inviting me.
Actually, before we start, the Philippine audience liked your talk with MSF before, a few weeks before, and they would like to invite you again for another talk with regards to MSF, something in the area of MSF.
Oh, okay.
Soon.
Okay, that would be nice.
Okay.
Hi, Professor Yunsuk.
Hello, good evening.
Hello, good evening, Prof. Anyway, we're just waiting for Ronson. I think Ronson is somewhere. Ronson.
Professor So, good evening. Good evening. Professor Shannon, Chan, Professor Tokunaga, Professor Asim and Professor Long, good evening.
Good evening. Hi.
Good evening, everyone.
Yeah, thank you again for the time and for sharing your expertise.
Good evening.
Sir Allen. Sir Allen.
Okay na.
Start na ba?
Ronson?
Yeah, good evening. Good evening po, sir.
And let's wait for Dr. Benafe to
Yes, sir.
to give us the go signal for this when a go signal to start. Is Sir Allen around?
Still fixing some.
Okay. Siguro Ronson, I think suggestion next time when there's still a lag, yung parang we have a lag time. Let's play some background music.
Yes, sir. We'll do that.
Di ba? Parang okay yun eh.
Vừa có feel chị Lão anh đang dạy học.
Mga tipong EDT.
Instrumental, sir.
Mga hindi, electronic dance music.
Okay.
EDM. Hindi, joke lang. Any kind of music will do.
Là để tao
Parang yung lag time natin na may music na napupuno.
Okay, while waiting, I would like to welcome everyone for the 14th UMIST weekly teleconference and our 4th gastric lecture series, our last lecture series for gastric surgery. So, first of all, I would like to thank the 5 professors, Professor Long, Professor Sim, Professor Shannon Chan, Professor Tokunaga, and Professor So. We have five international experts from Vietnam, Singapore, Japan, Korea, and Hong Kong who will share their expertise on these topics. I would like to also thank our director of the Unified Minimal Invasive Training Program, Dr. Allen Alfred Buenafe, and the three chairmen of the institution, Dr. Ray Sarmiento, Dr. Avery, and Dr. Palines. There's just some technical problem we're fixing. We'll start in a short while. I would like to also thank Dr. Edmond Orlina, our moderator for tonight, our local panelists, Dr. Don Edward Roselio, Dr. John Bueno, Dr. Bernice Navarro, Dr. Arlene Cañones, and the UMIST technical team.
There's a comment here. There's lots of echoes. Can the technical team fix it?
Okay, sir. I'll let.
Yeah, Ray, we're experiencing some technical problems in the main room.
Chat nyo na lang, sir. Sino yung chat?
Nat, sino yung chat?
Ha?
May naka-online. May pa-off na isang video.
Nakamit ka? Ay, hindi.
Ayun, naka-online.
Okay, I think the echoes are gone.
So sorry for that. Ray, Professor
Yes, sir.
Simon Lau actually is in one of the participants. I asked
move him up to
panelist.
Yes, please.
Hi, Simon. Where's Simon? I think Simon now is being upgraded to panelist. Hi, Simon. Simon, I think you need to sign in again with your audio because I cannot see your audio, Simon. Try logging out again and then signing in again, and then we'll upgrade you again to panelist so we can start.
Hi. Can you hear me?
Yeah, Dr. Simon.
Good evening, Professor.
Can you hear me now?
Yeah,
yes, perfect.
Video from Simon.
Hi, everyone.
Hi, Simon. So anyway, I think it's already 7:10. Might as well start. What do you think, Ronson? Ronson, can you hear me?
Yes, sir. Again, good evening. Welcome to our 14th weekly UMIST teleconference and our fourth and last lecture series for the gastric surgery. So today, we are very honored and privileged to have five international speakers from Japan, Hong Kong, Singapore, Vietnam, and Korea who will share their expertise on these topics. So without further ado, I will first give you to our director, Dr. Allen Alfred Buenafe, to give the welcome remarks and also the three chairmen of the department.
Hello, good evening. Thank you once again for joining us to our weekly conference of the Unified Minimally Invasive Surgery Training Program. First off, I would like to thank our good friends from all over, from Vietnam, Vudoy Long, of course, Professor Masanori Tokunaga from Japan, Asim, where's Asim? Hey, Asim, where are you? Asim Shabir from Singapore, Shannon Chan from Hong Kong, and Professor Yoon Suk Soo from Korea. We're quite lucky. Uh, Two of our distinguished friends, good friends, one from Hong Kong, a very known surgeon for upper GI, Professor Simon Lau. Uh, he just came in as a guest, but now we're inviting him to be one of our panelists. And of course, Dr. John Andrew Bueno from the Philippines. Will be moderated by Dr. Edmond Orlina, and of course, Ronson. Ronson, let's introduce our three chairmen. First of all, UMIST is composed of three government hospitals. We're running a fellowship program. Uh, the hospitals of Rizal Medical Center, chaired by Ray Sarmiento, Batangas Medical Center, chaired by Dr. Palines, and Quirino Medical Center, chaired by Professor Romeo Obari. Can we call on Professor Ray Sarmiento first? Ray, let's give our welcome remarks.
Thank you, Dr. Alan. Well, I'm not a professor, I'm just a doctor. Uh, I'd like to defer the welcome remarks because I think Dr. Allen has given it. And thank you very much for joining us in this UMIST conference or webinar. So without prolonging we'd like to pass on the mic to the next to Dr. Palines, the chairman of Batangas Medical Center.
Yeah, good evening, everyone. And again, in behalf of the Batangas Medical Center, we would like to thank our 5 foreign speakers for sharing their expertise in the operative treatment of gastric cancer. So thank you very much. And again, congratulations, Alan, for a very interesting lecture series. Thank you.
Thank you, sir. Dr. Abari.
Yeah, thank you, Alan. First of all, good evening and welcome to our UMIS webinar. Yeah, and first of all, congratulations, Alan, being the program director, and yeah, me from and inviting 5 experts from the different Asian countries: Vietnam, Hong Kong, Japan, Singapore. Yeah, so I think this would be a very interesting night. So in behalf of Quirino Memorial Medical Center, yeah, welcome and thank you again.
Thank you, sir.
Back to you, Alan. Thank you.
Thank you, sir. Thank you. This is the last series of a 4-week gastric course presented by the gastric group of the UMIST program. The UMIST program from the 3 government hospitals. Our gastric group is composed of Ronsonang, and Dr. Edmond Orlina, and of course, Bernice Navarro. So I'll give it to the group of Emong, Dr. Orlina. Thank you.
Thank you very much, Dr. Buenofe. Good evening to everyone. Good evening to all our participants for today. We will now start with our program. So to introduce our first speaker, as we are preparing the slides of the first speaker, I would like to remind everyone, feel free to type your questions in our chat box if ever you have any questions. Our experts will be answering them in our open forum at the end of after all of their lectures. Or if you want to raise your questions verbally, you may do so by raising your hand in the Zoom app. Okay, can we see let's now start for our first speaker for tonight. So our first speaker is Professor Vodoy Long. Professor Long finished as a Master of Laparoscopy in the University of Catania, Italy. He has a PhD from the University of Medicine and Pharmacy of Ho Chi Minh City. He is the current head of Upper GI Surgery Division and Deputy Head of GI Surgical Department in the University Medical Center, Ho Chi Minh City, Vietnam. To share with us his experience in laparoscopic gastric cancer, let us all welcome Professor Vo Doi Long.
Whether you're
Long,
on
please
mute, you
unmute
need
your
to
mic.
unmute yourself. You need to unmute your mic, Vodoy. How to unmute?
Oops, you're still on mute.
Professor Long, please unmute your mic. Yes.
Yeah.
Yeah, we can hear you now.
Okay.
Yeah.
It's
And
okay
I was,
now.
I cannot to share my screening. Can you see my screening?
Share screen.
Yes, because I cannot to share my screening to share with you my presentation. Yeah, okay.
Okay, you can share your screen now, sir.
Yeah, it's okay?
Yes, sir.
It's okay now, Professor. Thank you.
Okay. Thank you very much. Firstly, I want to thank Professor Allen, my friend, invited me to share with you with my experience on the laparoscopic gastrectomy for advanced gastric cancer. This is my hospital, and this is my team. As you know that the gastric cancer is a very common disease in Vietnam. And as you know, until now in Vietnam, gastrectomy with lymphadenectomy dissection is the first choice for radical treatment. And we started performing the laparoscopic gastrectomy for gastric cancer since 2008. And in my hospital, every year we have about more than 300 patients with gastric cancer. Of these, about 70%, about 250 patients have indication for other radical gastrectomy. And we are building the guideline for treatment of gastric cancer. Like this. For the tumor with the M1, I mean distal metastatic, we only we use the chemotherapy for the patient. If the no metastasis, in the early gastric cancer, T1 we before ESD, and the T2 or T4 we before D2 gastrectomy. And if the tumor with the bulky lymph nodes, I mean that the diameter of the lymph node more than 3 cm, or the tumor with T4B, we before neoadjuvant chemotherapy. After 3 or 6 cycles, we restaging by CT scan. I don't know CT scan. If the tumor screening or the diameter, the lymph node screen, we before D2 gastrectomy. And until now, the indication for laparoscopy for gastric cancer in early gastric cancer is widely accepted, but advanced gastric cancer have some still controversial, as you know that. And in our hospital, we indicate laparoscopy for gastric cancer. In the first period of 2008 and 2011, we use for the T2 and T1 and the diameter of the tumor less than 5 cm. After we get some experience, and from 2012 until now, we open for the T48 and some case T4B. If the T4B without complication, disease complication, we perform neoadjuvant chemotherapy. If the tumor with disease complication such as the bleeding or pelvis construction, we perform the gastrectomy and combine some transfer colectomy, splenectomy, distal penectomy, something like that. There my the patient position. I present to you with some my technique. I use phytoca for this. The first I want to share my technique of distal gastrectomy. We can I perform the total omentectomy. And to dissect the group for SB by ligated the left gastroepithelial vessel, and dissect along the ridge curvature to remove group 4D, and control to the pancreas head to remove group 6 by ligate the right gastroepithelial artery and then an infrapyloric artery. and continue to what I said in the suprapancreatic area to remove group 5, transit duodenum, group 5, group 8A, 11, P, 9, and like that, you see, I make sure the principle of ultimate layer, left gastric artery, make sure the principle of ultimate layer to preserve the nerve surrounding the common hepatic artery, and group 11P, and to like that, the left gastric vein and right artery, left gastric vein, group 11P. I dissect the first surrounding the left gastric artery, left gastric vein, and after that I dissect surrounding from the group 9 to group 8A, 11, 12B, 12A, and like the left gastric artery. And we dissect until the posterior gastric artery until like that, and group 1, group 2, group 1, group 3 along the reticular curvature, and transect the stomach, and after before the lymphadenectomy for distal gastrostomy, you see all lymph node have to remove. Okay, and for total gastrostomy in the similar group 6, and for the total gastrostomy with advanced gastric cancer, we perform routinely the highly subplanic hilum lymphadenectomy. You see, I dissect along the subplanic artery and its branch to remove the group 11P, 11D, and group 10. I dissect along the subplanic artery and like the posterior gastric artery. You see, posterior gastric artery and the short gastric vessel, and to remove group 10, group 4 SPA, and to transect the esophagus. You see, after before total total gastrostomy with total lymphadenectomy. You see, for the Bunky tumor, this tumor is a Bunky tumor and the T4A. But we should, if this patient no complication, we can use a neoadjuvant chemotherapy for patient, and up to 3 cycles, 6 cycles, we can before gastrostomy is better. But the patient have a complication with bleeding. We cannot control by endoscopy. So we decide to perform gastrostomy with total gastrostomy. You see the video clip with a Bunky tumor, and the techniques I think are not very difficult. It's similar the other technique. We transect the duodenum, and before lymphadenectomy, the suprapancreatic area, posterior gastric artery, and to before lymphadenectomy in group 11D and 10. In the group 10, this is transect the short gastric vessel. You see many lymph nodes after for lymphadenectomy for the Bunky tumor. You see, and for bursettomy now some surgeon told us bursettomy is not necessary and not good for the for the patient with survival. Not it's good for survival, but you see some author they can present the result of the bursettomy, and some case some report it so fast due to resection with bursettomy is better and safe and is feasible and better to compare with without bursettomy. You see some the author Marone Zhu, some the especially some the Chinese author right present the bursettomy, some routing for the tumor with T4A. And our hospital, we some before bursettomy, some selected patient with T4A, and especially the tumor located at the posterior gastric wall. For the technique, you see, not very difficult. We remove the anterior lip of the transverse chromosome or pancreatitis. We use the spatula to perform similar to the pronation. For the technique, I think that not very difficult, and it's safe. But we wait the result for the oncology outcome. You see, after before vasectomy, like this. For the lymph anatomy group 12B and P, because group 12, including group 12A, 12B, and P, we indicate lymph anatomy all group 12, including 12B and B for the tumor with T3 and T4A, and the tumor located at the pylori. And for the splenicular lymph anatomy, in the new guideline of Japanese, not including group 10 for total gastrectomy, but some guideline for in the early guideline is including group 10. For in our hospital, we indicate splenicular lymph anatomy for the tumor with T3 or T4A, and the tumor located at the middle or upper third of the stomach, and total gastrectomy or nearly total gastrectomy. The small technique, short video technique of splenicular lymph anatomy. And I said along the splenic vessel and its branch to remove all the lymph nodes and the conductive tissue along the splenic artery and its branch and along the spleniculum to remove all the lymph nodes and ligate all the soft gastric vessel from origin. And you see that all the lymph nodes, you see, have to remove with a very safe technique. 44B, and I have just mentioned that if the no disease complication, we use the neoadjuvant chemotherapy, and after that we do D2 gastrectomy. But if some patient with disease complication, with no medical control, we burn for gastrectomy combined resection, and especially the complication with pyloric obstruction. We've choose the option that the first surgery will be for gastric partitioning gastrojejunostomy, and we use the neoadjuvant chemotherapy after 3 or 6 cycles, and after that we do D2 gastrectomy. The patient with the tumor in the pyloric complication with the pyloric obstruction with T4B, and we before the first surgery either gastrojejunotomy. You see, I translate the stomach, and we before gastrojejunostomy to treat the for patient have for feeding by mouth, by oral feeding. And after that, we use the neoadjuvant chemotherapy for 3 cycles or 6 cycles. After that, right before lymphadenectomy. You see, after before lymphadenectomy, I don't before any anastomosis in the second surgery. I only translate the random stomach, and you see the prior anastomosis. And after before lymphadenectomy, you see this duodenum stump and the prior anastomosis. Yeah. So for the advanced gastric cancer, you see laparoscopy is the acceptable technique. As some the author from the Korea represent many reports so that this laparoscopy for advanced locally advanced gastric cancer is safe with the early complication, and the somatic early complication is acceptable. And Dr. Masaya in Japan and Uzama, I performed the obstetric report. They conclude that laparoscopic gastrectomy for advanced gastric cancer to be safer and safe with the rate of complication and early and late is acceptable. Dr. Shin Lee from Korea compare early gastric cancer and advanced gastric cancer, and they saw the result is the similar the result of to compare early gastric cancer and advanced gastric cancer. And Dr. Priyan from the Hong Kong, they compare the laparoscopic gastrectomy and open gastrectomy. They saw the same result with the minor complications. Also for minor complication is lesser than in laparoscopy to compare open gastrectomy. In the Professor Han Guan Yan and Dr. His Chun Lin from Seoul National Center compare the laparoscopic gastrectomy and open gastrectomy for gastric cancer, and they give this result with the overall mobility is lesser than in laparoscopic gastrectomy, and they conclude that laparoscopic gastrectomy for local advanced gastric cancer is safe and sort of benefits some benefits of a lower complication and other benefits for patient. And Dr. Karatina Bayer, before the meta-analysis, they showed the similar result. And the very new report from Dr. Wu Jin Huing from Korea have just published in 2020, compare 490 patients with laparoscopic gastrectomy compared to 482 open gastrectomy for locally advanced gastric cancer. So first, the result was in early complication is better than in laparoscopy, significant less than in laparoscopy, and the bleeding the anatomic leakage of bleeding is less than in laparoscopy. And for they conclude all the complication with the clavidelino right is not different between two techniques. And I want to show you our personal result for my personal number from March 2010 and to March 2020, about 10 years. I may say performed about 825 patients with gastric cancer. And of these about 660 patients with left distal gastrectomy and 165 patients with total gastrectomy. And about the complication is less than 1%. You see, less than 1%, and the mean hospital length stay as for 75 days. And as you know, 3 years later, from 2018, 2019, and 2020, we had no patient with complication, leak and bleeding. And I have just saw that for 3 years later, we have no bleeding, no leak in my number. So thus, I think that laparoscopy for advanced gastric cancer is feasible and safe. And how about the laparoscopy for advanced gastric cancer acceptable for oncologic outcome? Some other authors present the early outcome, oncologic outcome, and 3-year oncologic outcome. They compare open and laparoscopic gastrectomy. That's what they the similar result for oncologic outcome. Dr. San Honrich and Rosenbach compare like this. It's acceptable oncologic outcome. You see, in Japan, Dr. Uzama saw the very good result for advanced gastric cancer, and Dr. Professor Gu Xin Li from China saw that the result for oncologic outcome is similar for laparoscopic and open. And similar, Dr. Priyan in Hong Kong with the saw that the disease recurrent 9% laparoscopy and open in 28%. You see that the disease recurrent is better than in laparoscopy. And the new report of the Wu Xinhui, they saw the similar 3-year relapse-free survival in laparoscopy compared to open. It is similar with P significant P about 0.7. In our result, the totally this 1 year about 93% and 3 year about 85% and 5 year about 80%. And we compare with the prior data. We compare the locally advanced gastric cancer of 755 laparoscopic gastrectomy versus 620 open gastric cancer. You see, for the recession lymph node is similar. Overall complication is similar in two technique. Anatomic leak is more than in open gastric cancer, but it's not significant. And also overall survival outcome are comparable in the laparoscopy. You see. So I can conclude that laparoscopy for advanced gastric cancer is acceptable oncologic outcome. For advanced gastric cancer, we can perform function by preserving gastrectomy with the tumor in the upper third of the stomach with T1, T2, and angiozo in the group 4D, 6, and 5. If and no lymph nodes, we can perform the proximal gastrectomy with Kamikawa technique. In the past, we perform open, and we perform reconstruction by gastrointestinal esophageal gastrostomy or double track. But now for laparoscopy, we use the Kamikawa techniques. It's similar the picture like this, and I'll show you a short video for the proximal gastrectomy with Kamikawa technique. Firstly, I hands on the stomach, the left lower stomach, and before lymphadenectomy in the suprapancreatic area and group 10. This patient we perform fluorescent session group 4D and 6 is a negative for cancer. So I decided to perform the proximal gastrectomy. I mobilize the esophagus as long as possible. And after that, I perform endoscopy to make sure where the tumor and to transect the esophagus. After perform lymphadenectomy in superior pancreatic area. And I mark the esophagus and to open a small incision and to remove the specimen and to make the double flap outside by open surgery with the side of the flaps and 3.5 cm. And the first, I fix the posterior stomach wall into the posterior esophagus wall by interrupted suture. You see, and the second layer we before anastomosis between posterior wall of the gastric, but it's only the you see, it's only the mucosa and submucosal layer in the posterior wall of the esophagus, and to suture the anterior wall of the stomach and in anterior of the esophagus by total suture. And after that, we cover the anatomy by two flaps we said before. You see, to cover, and I mean that we bury the anatomy into the submucosal layer of the stomach. You see, after before anastomosis. Okay. And the second technique, for example, the tumor in the middle third of the stomach. Sometimes we perform the nearly total gastrectomy. Nearly total gastrectomy, that means we preserve the cardiac, and we preserve the last the short gastric vessel, and to perform anastomosis with the gastric stump to genome. You see, I show you some small video clip with tumor in the middle third of stomach. For the technique before lymphadenectomy is similar. Total gastrectomy. We perform the lymphadenectomy group 6, group 5, and infra suprapancreatic area. Okay, remove the duodenum and group tail A and lymphatic cancer. And as I said, along the splenic artery, and it's planned to remove group 11A, I'm sorry, 11P, 11D, and after transit the stomach from the cardiac and before fluorescence session for proximal margin to make sure that proximal margin is negative. And I continue to perform lymph anatomy group 10 and we preserve the last gastric vessel. And you see after perform lymph anatomy and to perform reconstruction by Roux-en-Y method. Okay, Roux-en-Y method. Yeah. And you see, in IBGCC have just organized before the COVID in February in 2020, the board member meeting. And I am going to perform the ongoing research. I have just published on the clinical trial. We compare, I am recruiting the patient for research, comparison of open and laparoscopic digital gastrectomy for T4A gastric cancer. We randomized to 240 patients. And we hope that we finish the recruiting patient 2023 to compare for how about the compare. I hope that the laparoscopy is superior for T4A gastric cancer. And I am performing some research like this for ICG, for mapping lymph node, robotic surgery, and like this. And this patient. And we conclude this gastric cancer is a common disease in Vietnam, mostly in advanced gastric cancer. And until now, I conclude that laparoscopic gastrectomy is technically feasibility, safe technique, and providing an acceptable oncologic outcome. And we need more randomized control trial to confirm the good long-term oncologists. It's my city. Thank you very much for your attention.
Okay. Thank you very much for that very enlightening talk, Dr. Long. To our participants, you may key in your questions if you have any questions, and Professor Long will be answering it later at our open forum. Let's move on to our next speaker, Professor Shannon Chan. Dr. Chan graduated from the Chinese University of Hong Kong. She completed general surgical training and received fellowships from the College of Surgeons of Hong Kong and Royal College of Surgeons of Edinburgh. Dr. Shannon Chan is currently an assistant professor in the Division of Upper Gastrointestinal and Metabolic Surgery of the Chinese University of Hong Kong. Apart from her research interests, Dr. Chan has also devoted herself to humanitarian and aid work. She joined the Doctors Without Borders in 2014. And now, to share with us her knowledge on combined endoscopic and laparoscopic approach for gastric tumors, let us all please welcome Dr. Shannon Chan.
Hello, so thank you, Ray, and thank you, Ellen, for inviting me for the talk. So let me share the screen. Can you see it?
Yeah.
We can see Shannon.
Okay. Also, thank you, Professor Long, for the lecture on the advanced laparoscopic gastrectomy. I'm really impressed with the numbers and the technique that you performed, especially with the Kamikawa technique. I know that it's a technically very, very difficult surgery to perform. So we're trying to move the topic a little bit from advanced cancers to more earlier cancers. And the topic I was given today was combined endoscopic and laparoscopic approach for gastric tumors. So I'll first start to illustrate the concept of the combined endoscopic and laparoscopic approach with GIST first, and then we'll move on a little bit to early gastric cancers and how we can apply this technique in early gastric cancers. So first, let's start with the GIST. So gastrointestinal stromal tumors, by the ESMO guideline, the management, standard management should be complete surgical excision with no dissection of clinically negative lymph nodes. And if laparoscopic excision is planned, the technique needs to follow the principles of oncological surgery. So in these guidelines, there was not a single comment on endoscopic resection or combined endoscopic laparoscopic resection. So let's go back a little bit into the evolution of tumor surgery and the evolution of a GI endoscopy. So when tumor surgery first started, the principle was to perform safe surgeries to at least have a good outcome. And then people started to request more, so that we need to perform oncologically clear surgery. So then it started the concept of D1, D1 plus and D2 lymphadenectomy for gastric cancers. And then we move on a little bit now more to function preserving surgery. So including minimally invasive surgery, laparoscopic and robotic, which Professor Long has mentioned in his talk, and a little bit more to function and organ preserving surgery. As for GI endoscopy, so a long time ago, it started with just diagnostics. And recently, we've been very lucky to have great advancement in therapeutic resection, including polypectomy, EMR, and also ESD. And then we started to move a little bit more from the luminal side to one layer each time forward. So we started with the mucosal layer with polypectomy, EMR, and ESD. And then we took a bit more to tunneling resection, such as a pulpit resection. And finally, nowadays, GIST can be removed with the endoscopic full thickness resection. So can we combine the two concepts together in treating GIST or early gastric cancers? So the concern of endoscopic resection of GIST is first oncological resection. So could an R0 resection be achieved? Most of the time we can. If we do a full thickness resection, can we close the defect adequately? And third, if we remove the lesion from the luminal side, that is the endoscopic side, can we remove the lesion from the mouth? Is there a limit to that? And third, when we perform these combined resection, is there a risk of peritoneal dissemination when performing the endoscopic full thickness resection? This still needs long-term data to prove. So the problem with resecting GIST and also for early gastric cancers is when the GIST presents as an ulcerative tumor. So if we just do an endoscopic full thickness resection, we expose the ulcerated segment to the peritoneal cavity and thus causing the risk of peritoneal seeding. So simple laparoscopic wet resection, you only need to go on with a laparoscopic stapler to achieve a margin negative resection. And you try to preserve as much normal stomach as possible, that is function preserving. And we try to avoid major gastrectomy. However, there's problems with this technique. First, if the tumor is very near the two ends of the stomach, for example, in the cardia or in the antrum, then wedge resection is not possible due to the risk of stenosis. And with these locations, significant amount of adjacent normal stomach is removed with the wedge resection and therefore affect the functional outcome. So then the first concept of combined laparoscopic endoscopic cooperation surgery, that is we call the LEX surgery, was reported by Hiki Sensei more than 10 years ago. So the initial concept was first we start luminally, like an ESD procedure. We mark the tumor and we cut the mucosal layer of the tumor circumferentially. And at the same time, we also cut the serosal layer on the outside laparoscopically. And afterwards, we kind of, it's like a rendezvous technique where the laparoscopic surgeon and the endoscopist first meet each other. And then we can use a laparoscopic stapler to close the defect that was created with this full thickness resection. But with this technique, The problem is that the tumor is exposed to the peritoneal cavity, and especially with tumors, for example, ulcerated cyst or gastric tumors, we try not to expose the mucosal side of the tumor to the peritoneal cavity to avoid peritoneal seeding. So the first reports on this we call the classical lex was published in 2014. This meta-analysis concluded the outcomes of this classical lex. So you can see that the complication rate is very, very low. The mean hospital stay is a bit long, probably due to the initial pilot studies of the procedures, and therefore people tend to be a bit more cautious. But with this technique, you can see that the functional outcome is that only 9% developed gastric motility disorder on follow-up endoscopy, meaning that with this technique, a lot of patients has better functional outcome than a laparoscopic wedge resection. So as previously mentioned, the limitation of this technique is that there is peritoneal contamination of the tumor cells and gastric juice, which causes peritoneal seeding and recurrence. So then modified technique was subsequently developed. First, the inverted lex procedure. And so the difference with the classical lex is that before they do the full thickness resection, they would sling up the edges of the resected specimen. So then the specimen would be inverted into the lumen of the stomach. So then the specimen would be retrieved perorally to decrease the seeding from the peritoneal cavity. But as you can see, with the laparoscopic approach, it's actually very difficult to sling up all the sides because you all have a very limited number of working hands. So then a more advancement came. So then it came along with the clean net technique. So this is what we call the non-exposed technique. So with this technique, it means that the tumor will not be exposed to the peritoneal cavity at all. So how it is performed, so you can look at the diagram. So assuming this is the lesion that we want to resect, the red color line is the mucosal layer. This thick layer is the serosal layer. So first we open up the serosal layer around the tumor, and we inject some hyaluronic acid as in ESD to separate the mucosal layer from the submucosal layer. So after we open up the serosal layer, we kind of tag the lesion up and staple off the submucosal layer. So with this technique, the tumor, even if it involves the mucosal side with ulceration, the mucosal side would never be exposed to the peritoneal cavity. So the first series was actually published by Inoue Sensei in 2012 over 24 patients. And with this technique, the complication rate was very, very low. So this is the video performed in our center a few months ago. So first, we start with exposing the lesser sac and exposing the tumor. So this is a gist. So then we open the serosal cervix. At the same time, the endoscopist on the inside would inject hyaluronic acid to separate the mucosal layer from the submucosal layer as in the ESD technique. So on the outside, the laparoscopic surgeon would start dissecting the serosa. So you see these light blue colored fluids was the one that is injected from the inside. So with careful dissection, we completely lift the lesion away from the muscle layer while keeping the mucosal layer intact. So you can see that this line is a mucosal layer inside. So with the mucosa intact, we would fire off the staple, and with the help of on-table OGD, we would check that the important inlets and outlets are intact. So the staple is actually fired on the mucosa surface only. So our specimen now is out and put in a specimen bag. And after the mucosa has been stapled off, we would suture the serosa layer together. So you can see that with this technique, there is actually minimal loss to the stomach surface. So the function of the patient is preserved, because if you imagine the lesion on the lesser curve, if we are to do a wedge resection, there would be a lot of gastric deformity with simple laparoscopic wedge resection. So with this technique, we push the tumor towards the laparoscopic side. So what if the lesion is more on the inner side, on the luminal side of the gastric wall? So there is a procedure called the UMIST procedure, which just stands for non-exposed wall inversion surgery. So it's basically the same thing with the CleanNet. It's just that we do the procedure on the other way. So first we open up the serosal side of the stomach laparoscopically. Then we push the lesion towards the luminal side, and laparoscopically we first close off the serosal layer, and then luminally the endoscopic surgeon would do ESD to take this lesion out. So a few case series has already been published on this technique quite a few years ago, and the ulnar resection rate is 100%, and the complication rate is actually relatively low. So for example, these lesions, which are more on the inner side of the stomach, would be suitable for the UMIST procedure. And the lesions, the size limit would be 3 centimeters, because you can imagine that the lesion will be pulled out from the mouth. So if it's too huge, you will not be able to pull it out. So first, again, there is solutions injected into the submucosal layer. And we open up from the laparoscopic side, open up the serosal layer until you see the submucosal layer. And this is a spacer, which you insert into it. The use of the spacer is to increase the distance between the lesion and the serosal wall to make the ESD much easier. So now we've closed off the outside. So then we move on to the inside to continue the ESD procedure. So it is important to mark the lesion before you start all the injection, or else you would lose the tumor, as there would be a lot of swelling and the injection would blur the borders of the tumor itself. So first, as usual, ESD, we open the mucosal layer, and then you will start to see the spacer, which you have inserted laparoscopically just now. So then you can retrieve the specimen perorally together with the spacer. So these are the sutures which we have applied laparoscopically. And then the mucosal side could be closed with the metal clips. So you can also see that minimal stomach was resected together with the specimen. So again, it is a very neat surgery, preserving function for the patient. So the comparison of the different types of the legs procedure. So first, the classical legs by Hiki sensei, and then the inverted legs, and the endoscopic full thickness resection with laparoscopic assistant. and the CleanNet and the news procedure. So you can see that the length of time for most of the procedures are very similar. And for most of the procedures, there is no limitation to the tumor location. But for CleanNet and news, it would be difficult to perform these procedures near the OG junction, and for procedures near the pyloric ring, because of the possibility of inlet or outlet stenosis. And for lesions, which the specimen has to be removed per orally, there is a size limitation to 3 centimeters. And the suturing technique is very similar in all 5 techniques. So can we move a step further to resect these GIST lesions with the NOTES procedure? So we can actually do that. So we have several options. So first we can do an ESD, or we can do the STIR procedure, or also called the POET procedure, which is submucosal tunneling endoscopic resection, or we can also do endoscopic full thickness resection. So for lesions, which are almost entirely on the luminal side, it can be easily resected with the ESD technique. This lesion is a bit more difficult on the fundus because of the breathing and because of the scope position. So basically, it's just normal ESD. You mark the lesion, inject into the submucosal surface, and then dissect from the submucosal layer that you have separated. So in this technique, we used the DO knife and the IT knife. So a bit different from ESD is that because these GIST are usually arising from the muscle layer, so you expect there to be a small muscle defect if you are aiming for an ulnar resection. But these could be easily closed with a metal clip, and then we can also close the whole mucosal surface with metal clips. So for the STIR procedure, it's a bit similar to the POEM procedure. So POEM procedure is the indication for achalasia. And however, with the same technique, we can also excise submucosal tumors usually located at the esophagus or the cardia or proximal stomach. So the simple technique is we incise the mucosal surface 3 or 4 centimeters above the lesion and create the submucosal tunneling like this. And once we've reached the tumor, we can resect around it. And after we resect, we can remove the lesion from the mouth. And after hemostasis, we can just close the mucosal incision that we have made. So this is actually a very, very safe technique to use. Okay, the video for this is not working. But nonetheless, it would be very similar to a POEM procedure. So there are publications on the submucosal tunneling technique arising from the MP layer. So there are actually 17 original articles that were arising with this technique, with including over 700 patients. And the lesion size are usually quite small, ranging from 6 millimeter to 5 centimeter. And the complication rate has a wide range from 0 to 42%. And the reason is because this meta-analysis actually included cases during the learning curve, leading to the higher complication rate. Otherwise, normally for experienced centers, the complication rate should be well less than 5%. And the hospital stay you can see is actually quite short, ranging from 2.7 days to 6 days, and almost 100% ulnar resection rate. And no tumor recurrence was reported in a median follow-up of 1 to 36 months. So then the endoscopic full thickness resection, it's basically endoluminal resection all the way down to the muscle layer and the full thickness resection. So after you resect the tumor, you can close the defect either with metal clips only or with endoscopic suturing technique, or if the defect is very large, you can close it with the clip loop technique, meaning that you can use the detachable snare that you use for polypectomy in colonic polyp. So you basically put the loop around the defect and clip alongside the clip onto the loop onto the edge of the defect. And then once you close the detachable snare, then the whole defect would close with the closure of the detachable snare. And it's actually a technique that is quite handy to use. And there are several papers published on this technique. And actually with the endoscopic resection technique, the complication rate is as low as 3%, and similar to the surgical approach with laparoscopic wedge or open wedge resection. In this retrospective review by Abe Sensei from Japan, they compared endoscopic resection, which includes ESD, EMD, and also endoscopic full thickness resection together with laparoscopic wedge resection. You can see that the operative time for endoscopic resection is much shorter, and the estimated blood loss is much less, and both groups was able to achieve R0 resection. The tumor size for the endoscopic resection is smaller, much smaller than that of the laparoscopic wedge resection, with a size difference of around 1 centimeter. And you can see that the complication rate of both groups are very low and very similar. There is also no recurrence detected, no difference in the peritoneal recurrence detected in both groups. So can we take this further to gastric cancer per se? So initially, the first guidelines with the Japanese gastric cancer guidelines is that the blue, the lesion size of the blue box is indicated for ESD, and then came along the expanded criteria where we can resect tumor size larger, but only for well-differentiated tumors. So the reason for not suggesting ESD for tumors of larger size or with the poorly differentiated type is because of the risk of lymph node metastasis. So for example, for lesions with a poorly differentiated type, even if it is less than 2 centimeter, there is a risk of lymph node metastasis, and for young fit patients, we do not want to miss this percentage. But this percentage is actually very, very low, only down to 2.8%. So meaning that if we go for gastrectomy for these patients, we are actually overdoing for 97% of the time. So can we accurately select these 2.8% out and leave the other 97% of the patient with just an endoscopic resection or with just a wedge resection? So the technique of the combined endoscopic and laparoscopic approach provides the non-exposed techniques with the LECS. And for the lymph node, there are currently investigations on the sentinel lymph node investigation. So this was named the hybrid approach. So first, the tumor can be excised locally with a combined laparoscopic and endoscopic approach mentioned just now. And with the use of the help of ICG and also with isotope, we can hopefully detect the sentinel lymph node basin to help us determine whether the patient has a lymph node metastasis. So the concept is a little bit similar to breast cancer. So the first prospective multi-center study in Japan was performed by Professor Kitagawa. So it included almost 400 patients. with the sentinel lymph node biopsies in 12 centers, though they only included early tumors of a T1 pre-op staging of T1 N0 M0 or a T2 tumors, and a primary tumor of less than 4 centimeter. So for this series, what they did was that they injected ICG and also the isotope to these tumors, and then they tried to identify the sentinel lymph node. So they would send it for histology separately with an ICG positive and isotope positive lymph nodes, and but they will perform formal gastrectomy and standard lymphadenectomy anyway. So in this in this prospective cohort, they found that actually in 97.5% of the time, they were able to accurately identify the sentinel lymph node with the accuracy of a metastatic status of up to 99%. And they also tried to send the sentinel lymph node for frozen section. However, the sensitivity is only around 78%. So in his 400 patient cohort, they found that there are a few cases of a false negative sentinel lymph node, and they identified the specific risk factors associated with a false negative sentinel lymph node, which is a tumor size of more than 4 centimeter, and tumors of a T2 staging would have a higher chance of a false negative lymph node. And that's why in this study, they concluded that sentinel lymph node biopsy is safe and effective for small gastric cancers. And the tumor size of less than or equal to 4 centimeter should be one of the selection criteria. So then there was another multi-center trial called the Senorita trial. So in this, this trial was just published in BJS in June this year. So for this, they included even earlier tumors. So the inclusion criteria was T1N0 as a pre-op staging with a tumor size less than 3 centimeter in diameter. So intra-op, they injected submucosally the standardized dual tracer, and all retrieved sentinel lymph nodes were investigated with intraoperative frozen section. So the dual tracer they used in this study was 2 mils of 2.5 per mil concentrated ICG, together with the technium radio-labeled human serum albumin. So 1 mil of the dual tracer was injected in the submucosal layer of the 4 quadrants of the gastric tumor. So 15 minutes after the injection, they would identify the sentinel lymph nodes. And if, for example, the station 7, there is 1 lymph node that is positive, then they would remove the whole basin. So they would not only remove the positive lymph node, so they would include the whole basin. So this is the technique that they use. So the black dot is the primary tumor. The hot node is the hot node from the technium, and the green node is an ICG positive node, and some nodes are both ICG and also technium positive, and the basin node meaning the whole station that was taken with it. So if they find that one of the nodes are frozen positive, then they would perform a standard gastrectomy and lymphadenectomy. But if the node is negative, they would just take out the whole basin and do a local resection of the tumor. So if the tumor is luckily in the greater curve, then a wedge would suffice. If it is in the middle, then they would do a segmental resection. If it is near the cardia or high lesser curve, then they would use some combination of technique with ESD and cervic full thickness resection or CleanNet or NUS that was discussed in previous slides. So it's interesting to see that there is actually almost 580 patients that were recruited. And in the laparoscopic sentinel lymph node group, there was 288 cases. So after all the exclusion of multiple gastric lesions, patient refused surgery, at the end they had 245 patients. And intra-op failure of stomach preserving surgery, there were 35 patients, and mainly 8 of them, they were not able to identify the sentinel basin, and 19 of them had an intra-op frozen positive. So 19 of them, of the patients, had a positive sentinel lymph node during the surgery, and that's why they proceeded to a standard gastrectomy and lymphadenectomy. And 6 of them had a positive tumor resection margin, and 1 had intraoperative bleeding, and 1 had significant gastric deformity after the stomach preserving technique. So at the end, they had 210 patients, but even with these patients, they had some of 12 patients, they had to take the patient in for reoperation, and 10 of them was due to there was a informal histology that the resection margin was positive, and 4 of them finally came back to be T2 or T3 tumors, meaning that they would need more curative resection, and 2 of them had an N1 positive, so meaning they sent the whole basin for histology. So intra-op frozen was negative, but histology finally showed up to be positive. So they had to take the patient in for more definitive surgery. And 2 of them had to be reoperated because of stenosis at the wedge resection site. So end up around 200 patients was included in the sentinel lymph node group. So it is interesting to see. So this paper, the primary outcome was the short-term outcome of morbidity and mortality with this technique. So you can see that this is the intention to treat analysis. So for this, it is more interesting to look at the per protocol analysis. So we really want to see how the sentinel lymph node group performed, and you can see that the percentage of post-op complications, there was no significant difference. So majority of both groups had class 2 complication. It was actually quite a little bit out of expectation, because you would expect a lower complication. Well, I would expect a lower complication rate for the sentinel lymph node group, but somehow it came out to be both groups came out to be quite similar, probably because the types of the postoperative complication, the majority was with wound infection. But this short-term outcome is actually interesting to see that at least the complication rate was not increased with the new technique. So the group is waiting for the long-term results. Of course, we are most concerned with the recurrence with this technique. So we are waiting eagerly for the outcomes of this long-term results. So in conclusion, the gastric tumors of the GI tract can be removed with several approaches. So it's either with the LEX approach, with ESD, with the STIR approach, or the endoscopic full thickness resection. It can also be removed with the laparoscopic wedge resection. And with this combined endoscopic laparoscopic approach, there is a very high on-block resection rate, and low complication rate could be achieved. And non-exposure techniques were developed to avoid tumor cell spillage, and that the laparoscopic sentinel lymph node surgery for early gastric cancer, as compared to standard gastrectomy, has similar short-term outcomes as with the Senarita trial. But more studies are required to compare the more important long-term outcomes of each approach. Thank you.
Thank you very much, Professor Chan, for that very interesting talk, and for sharing all of those interesting procedures. Before we continue, I'd like to recognize Dr. Don Edward Roselio from Cebu. Good evening, sir. Thank you for joining our panel tonight. Let's move on to our next. Thank you. Good evening, and then let's move on to our next speaker. Our next speaker is Professor Masanori Tokunaga. Professor Tokunaga had his surgical training in Aso Izuka Hospital, Fukuoka, and subsequently with the Department of Gastroenterological Surgery in Cancer Institute Hospital, Tokyo. Since then, he has been part of Shizuoka Cancer Center and National Cancer Center Hospital, East in Kashiwa. Currently, he is part of the Department of Gastrointestinal Surgery, Tokyo Medical and Dental University in Tokyo, Japan. He has numerous publications mostly on gastric cancer and related diseases. Tonight, he will share with us his knowledge on reconstruction after gastric resection. Let us all welcome Professor Masanori Tokunaga.
Hi, good evening, ladies and gentlemen. Can you hear me?
Yes, sir.
Yes, yes.
Okay, let me share my slide, my screen. Now I think you can see my screen. Can you see?
Yes, Professor.
Okay, thank you very much. And good evening, ladies and gentlemen. I'm Masanori Tokunaga from Tokyo Medical and Dental University. And thank you very much for inviting this wonderful opportunity. And I've already learned so many things from the first two speakers. And my topic is reconstruction after gastric resection. And I've heard my allocated presentation time is just 15 minutes. So I only focus on reconstruction after gastric resection and mainly the technique, laparoscopic technique. And okay, let me start my presentation. Okay, so what are optimal reconstruction method following gastrectomy? Of course, it is affected by several factors, type of gastrectomy, size of remnant stomach, and surgical approach. And today's my topic is reconstruction after minimally invasive surgery. So of course, I will talk about reconstruction following minimally invasive surgery. And also I'd like to focus on reconstruction following distal gastrectomy and total gastrectomy. And in this slide, you can see the incidence of gastric cancer all over the world. And in Japan, we have so many gastric cancers, and China, South Korea, and East Asian countries have so many cancers. So we've already conducted several clinical trials investigating the safety or efficacy of laparoscopic gastrectomy for gastric cancer. In this slide, this study was conducted a group named JCOG, Japan Clinical Oncology Group, one of the biggest study group in Japan. And in this study, we compared survival outcome between laparoscopic and open distal gastrectomy for early gastric cancer. And we also compared early complications following gastrectomy. And here you can see the anastomotic leakage rate was only 0.2% in both groups. So I think it's acceptably low, and I think we can do laparoscopic distal gastrectomy with very low complication rate. But this is the results of a clinical trial. I mean, the patient are highly selected, and of course, surgeon is also highly selected. And in this trial, we have limits the surgeon. For example, at least over 50 laparoscopic surgery or over 100 open gastrectomy before enrollment of this trial. And what about the real world data? And this is the result of nationwide registry data, and we compare early surgical outcomes between open and laparoscopic distal gastrectomy. And in each group, over approximately 15,000 patients were included. And you can see the post-operative leakage rate following laparoscopic distal gastrectomy was 1.9%. So I think this rate is acceptable, and we can continue to perform laparoscopic distal gastrectomy. And what about total gastrectomy? And this is again the same clinical trial group performed a single arm clinical trial, prospective trial. And in this study, we include in total of 244 patients, and all of them underwent total or proximal gastrectomy, and the leakage rate was 2.5%. And again, this is the result of the date of a nationwide registry. And here, the line with red line is the incidence of complication following laparoscopic total gastrectomy. In this case, the leakage rate was 5.4%, a bit higher than previous report. And in summary, here is the incidence of anastomotic leakage in Japan. Distal gastrectomy is 0.2% and 1.9% are both acceptable. But after total gastrectomy, 1 in 20 patients had anastomotic leakage, so it's a bit high. But this data was from nationwide registry 5 or more years ago. So now I think this rate has been decreased, and in my opinion, we can perform laparoscopic total gastrectomy with complication rate of 2 or 3% of anastomotic leakage. And what's the consequences following complication? Of course, early surgical outcome is affected very strongly. Anastomotic leakage is potentially fatal, and the patient have to stay at hospital, in some cases, a couple of weeks or a couple of months. And not only affect early surgical outcomes, but also complication affect long-term survival outcomes. This data is obtained from one clinical prospective trial named JCOB 1001. In this study, patient received open gastrectomy, is a distal total gastrectomy, and we compare survival outcome between patient having grade 3 or more severe complication and patient with grade 2 or less. And we demonstrated survival difference between the group. So if patient develop grade 3 or more severe complication, it affects not only early surgical outcome, but also long-term oncological outcome. So we should have special pay attention to avoid postoperative complication. And one of the big issue among surgeons is how we can perform secure anastomosis. And how we can do secure anastomosis, how we can make our procedure safe. I think the principle is similar between open and minimally invasive surgeries. The anastomosis should be tension-free, and we have to use the organ with sufficient blood supply. But in some part, the principle is different between open and minimally invasive surgery. And I think the device we use during anastomosis is different these days. 10 years or more years ago, Japanese surgeons prefer to use circular stapler for esophagostomy or gastroduodenostomy in laparoscopic gastrectomy, because we thought we should follow the procedure of open gastrectomy. However, these days we prefer to use this kind of linear stapler. I think this is the same in surgery in other countries. This device, this linear stapler, have several advantages. First, we can put this instrument to the patient abdominal cavity through trocar. If we use circular stapler, we have to make small incision, another incision. So I prefer this one. And another advantage is we can adjust the angle of the device here. And in this circular stapler, of course it's curved, but we cannot adjust the angle. So during laparoscopy, I think this anastomosis with linear stapler is better and preferable for all surgeons. So let me move to my movies. And the first one is build out one method following distal gastrectomy, and we named it delta anastomosis. Here you can see this is after gastric resection. And before this procedure, we measure the size of remnant stomach, and if we think we can make anastomosis without any tension, we go to build one method. But we think the size of remnant stomach is too small for build one reconstruction. We perform lower reconstruction. In this case, we had enough amount of remnant stomach, so we performed build one method. The movie is not so smooth. Okay, here. This is kind of end-to-end anastomosis. Okay. And we use a 45 millimeter linear stapler. And this anterior hole can be closed either manually or using a linear stapler. Because running suture with V-lock is also a very nice procedure. And in this case, we close the anterior hole with this linear stapler. Much easier and time-consuming way, but not cost-effective. So we want to save cost. We should close the anterior hole with strings with hand saw technique. And this is the final shape of anastomosis. Quite similar to anastomosis with circular stapler. And patency is very nice. I think the patency is much bigger than the circular stapler with 25 millimeter. So in all cases of distal gastrectomy, we use this procedure, direct anastomosis with linear stapler. And next is total gastrectomy. Surely, esophagojejunostomy is technically demanding procedure, and it can cause severe complication once anastomotic leakage happens, and it can be potentially fatal. So we have to avoid any kind of complication. And in this procedure, we prefer to use, again, linear stapler. And in this way, we connect esophagus and jejunum, and we call this procedure overlap method. It was introduced by Professor Uyama in Japan maybe 20 years ago. Okay. And before demonstrating the reconstruction, let me show a brief video clip of lymph node dissection. And this patient has had EGJ cancer, adenocarcinoma of esophagogastric junction. And these days, the incidence of AEG is increasing in Japan. And we have a lot of chance to perform this kind of surgery. In this case, the length of esophageal invasion is 2 centimeters. So we have to transact the esophagus 4 centimeters or 5 centimeters above the EG junction. And in this case, the tumor depth was T2. And now you can see our cardiac pericardium and thoracic membrane. And this case is T2 or T3 gastric cancer, so it's impossible to identify the location just with this view. So we use intraoperative endoscopy to confirm the location of the tumor and to confirm secure resection margin. Okay, now it's ready. And if we connect esophagus and the jejunum with linear stapler, we have to mobilize esophagus at least 40 millimeter or 45 millimeter. It's the length of linear stapler we use for reconstruction. This is a video for esophagojejunostomy. It's the same case, same patient. And now you can see illumination, it's endoscopy, and we already confirmed and cut the esophagus. and I cut the esophagus ventral dorsal direction because in case we reject 3 or 4 centimeter esophagus, so in this case, the site of anastomosis is lower mediastinal, and the space we can, it's easy to, yes, in this case, it's easy to have the space behind the stomach, behind the esophagus. But a bit difficult to find the space left side or right side of the esophagus. So we usually connect jejunum dorsal side of the esophagus in this way. Okay, now it's ready to fire. And I prefer to use this device, this stapler. We can change the angle very easily. We can adjust everything just single hand. Okay, now and confirm the patency, and we close the entry hole. In this case, we use interact suture and hands-on technique. Maybe it's possible to close this entry hole with linear stapler, but I worry about the stricture, and I prefer to use usual 10 to 12 sutures are enough to completely close. And then finally, I confirm the patency. As now we can see. We call this procedure air leak test. We ask anesthesiologist to put air through another gastric tube here, and we confirm no air bubble and no major leakage. And in this case, patient discharged from the hospital 7 days after the surgery. And of course, we hope every procedure can be done as I showed. I mean, every procedure, I hope, should be safely performed, but sometimes trouble happen. And in this last video, the typical error and have to overcome the error. Okay, this is robotic gastrectomy and esophageal jejunostomy. We connected. Now we thought we had connected, but okay, now no lumen. Unfortunately, the linear stapler migrated submucosal layer of the esophagus. After this accident, we put one suture before inserting a linear stapler to avoid a migration. And in this case, we just cut mucosal membrane and reinforce the anastomotic site. Maybe this reinforcement, as some say, this reinforcement is not necessary, but in this case, I was worried about. And also, in this case, we use robot, and as you know, robot is very nice for suturing. So we reinforce the anastomosis, and the entry hole was also closed continuously with this prelock plus prelock. Okay, this is final shape. Unfortunately, this patient's postoperative clinical course was uneventful and discharged 7 white postoperative day. Okay, so this is my summary. Actually, I think for safe anastomosis, principles are not different between open and minimal invasive surgery, tension-free and sufficient blood supply. And so we have to use device very carefully, and we have to know how we should apply the device and what's the drawbacks of each procedures. Okay, thank you very much for your kind attentions.
Thank you. Thank you very much, Professor Tokunaga, for that very enlightening talk. Our next speaker had his medical training in Seoul National University and continued with his master's and PhD at the same institution. He finished his fellowship in the Division of GI Surgery in the same hospital. Currently, Professor So is a professor of surgery in the College of Medicine in Seoul National University and is also active in the Seoul National University Hospital. He has over 80 research publications to his name. To deliver his lecture on single port surgery for gastric cancer, let us all welcome Professor Yoon Suk So.
Thank you for kind introduction, Mr. Chairman. Can you hear me?
Yes, sir.
Yes, I will start my share my screen. Can you see my screen?
Yes.
First of all, I have to present my sincere gratitude to the training program chairman. And it's really my really my honor to present my personal experience of single instant gastrectomy for gastric cancer. This is my conflict of interest. Well, the single incision laparoscopic surgery originally came from the appendectomy and also the cholecystectomy. The possible advantage of this type of surgery may be cosmetic first and maybe less pain. And the other side of the disadvantage is it may be a very difficult technical difficulty, and also the very low competence for unexpected intraoperative accident like bleeding. And also you may expect an earlier recovery. Also, maybe the similar oncological safety or may not. And recently, this type of surgery evolved to the colorectal cancer and also the gastric cancer as well since 2011. The first report of this single instant laparoscopic gastrectomy came back from the 2011 by Dr. Takeshi Omori in Japan. In 2011, he presented the 7 cases of single incident distal gastrectomy using the 2 millimeter medium loop assisted retractor. And in this paper, he performed the D1 plus beta lymph dissection, and there was no serious complication or there is no mortality. And he used only the 2.5 transumbilical single incision in here. And also our institution, Dr. Do Jun Bak, he performed 10 porcine model comparing single instant distal gastrectomy as well as conventional laparoscopic distal gastrectomy. He also used the 2 millimeter size assistant trocar here, and here you can see that a single incident port. In this paper, our team shows similar weight loss and similar inflammatory reaction, and also the similar not different morbidity and the number of retrieved lymph nodes. After that, this year, Korean Gastric Cancer Association is now performing the nationwide survey performed in 2019, and the data is now collecting through the March 23rd to the July 27th. This data is also now premature and still ongoing. The data is, until now, data is collected from 46 institutions in Korea, and you can see here, there's 14 institutions, 30.4% of institutions registered their experience of reduced port gastrectomy. Then the largest institution is our institution, and half of them is a single incision and half of them is a 3-port gastrectomy. Well, my personal experience is back to the March 2014. Originally, my case indication was clinical T1N0M0 early gastric cancer without any significant systemic comorbidity. Also, at my initial experience, the obesity should be acceptable, like a female less than 25 or a male less than 23. But nowadays, only all types of early gastric cancer can be the indication for the single incision distal or total gastrectomy. The basic position is lithotomy with reverse Trendelenburg position, and depending on the obesity or tumor size, 2.5 to 3 centimeter transumbilical incision made here, and there is no additional basically there is no additional abdominal port. And I also use the 10 millimeter flexible 3D laparoscope, and the grasper is 43 centimeter long straight graspers, or sometimes it's not so frequent. Sometimes I use the 35 bending graspers as well. And also I use the flexible 4-channel single port for this type of surgery, like this. And this is a typical scenario of my surgery. I sit down between the two legs of the patient, and she is the scopist for my single incision gastrectomy. We used only one screen to share for me and as well as the nurse and the scopist. This is a bird's eye view of this my surgery. Only the single incision port here, and this is the end of the surgery. I used one drain for all types of gastrectomy, including total gastrectomy, and there is no additional port here. I will show you that I will show my short video clip for single incision distal gastrectomy with D1 plus nuclear dissection. I used the flexible 3D flexible scope, so this is a typical view of partial lumpectomy. I click the left gastric epiploid, and this is the right side of partial lumpectomy. And proceed to surgery to the end of the to expose the duodenum first portion. As you can see here, you may see that anterior surface of pancreas. And you should remember that this patient had early gastric cancer. So I didn't try to the massive meticulous dissection like a D2 lymph node dissection. This is only the D1 plus. And there's a lot of right gastric epiploid. Yeah, the isolation of the right gastric epiploid vein. Ligation. And the dissection around the right gastric epiploid artery and the infrapyloric artery. Yeah, the completion of the lymph node dissection 6. And this is the posterior side of our right gastric artery. Also the dorsal side of right gastric artery and the supraduodenal artery and vein. Dissection of the root of right gastric artery. Yeah, you can see that the root of right gastric artery. Irrigated, transected, and transection of the duodenal first portion. And then we can go to the patient number 8. Yeah, station number 8A. Yeah, still proceed the dissection to the station number 9. And here is the station number 11P. Based on the guideline for early gastric cancer, we don't have to do the massive meticulous dissection around splenic artery for D1 plus lymph node dissection. But anyway, in this video, I visualize splenic artery and part of splenic vein as well. Yeah, isolation of the left gastric vein. Also the root of left gastric artery. In this patient, there is a replacing left hepatic artery originated from the left gastric. So I preserve the root of the left gastric artery and preserve the replacing left hepatic artery as well. So dissection around the trunk of the left gastric artery using this single incision distal gastrectomy, and isolation of the branch of the left gastric and transected, like as you can see here. So this is the part of vagus nerve. And the branch of the left gastric as well. And go to the station number 1, paracardial lymph nodes. Yeah. As you recognize here, there is no cystine during the surgery and a completion of the lymph node dissection. And section number 6. Based on the evidence, academic evidence of PubMed publication from Korea, as of July 14 and this year, from the 2011, there is a slight increase of the publication, and from the 2016, there is a steady state of publication status. As you can see here, there are 4 comparative studies comparing single incident gastrectomy and the multi-port gastrectomy. All the other publication is just a case series or a small number of the reports. In 2014, our institution reported our own initial experience comparing single incision distal gastrectomy and multiple distal gastrectomy. There is significant less blood loss in single incision distal gastrectomy here, and there is no difference of early complication less than 1 month after operation, and there is no mortality in these 2 types of surgery. Only one serious complication, like an intra-abdominal abscess, which was similarly found in 2 groups. But there are some raise a question. You may raise a question that is that a really clinical significance of this type of this difference of blood loss? And 2016, Dr. Omori he presented reported propensity score matching analysis comparing single incision distal gastrectomy and multiple gastrectomy. Also in this report, you can see that there's significant less amount of blood loss in single incision gastrectomy group, but in terms of the number of estimated lymph nodes, there is no significant difference between these 2 groups. And also you can see here, as you can see here, there is significantly less use of painkillers and shorter hospital stay and less inflammatory reaction in single incision distal gastrectomy compared with the multiple distal gastrectomy. Also, in terms of survivor, there is no difference of overall survivor as well as a recurrence-free survivor between the multiple and single incision distal gastrectomy in this propensity score matching analysis. The single incision gastrectomy for gastric cancer can be considered as a part of a new procedure to treat the gastric cancer. To generalize this new procedure, the procedure should be the simple and safe and also the reproducible. Also to do this, equivocal evaluation and validation for lymphadenectomy also as well as a reconstruction should be considered. But without any assistance, this reconstruction may be considered as a very difficult procedure. In this paper, Dr. Kunisaki, he reported that the reconstruction in reduced port gastrectomy may be totally different concept that compared with the conventional laparoscopic distal gastrectomy. And he also reported that the 40 cases may be required to achieve the adequate field dissection. And also 30 cases may be required to overcome the reconstruction. So the reconstruction, it may be a matter of the feasibility, and lymph node dissection can be considered as a matter of efficacy. For the reconstruction, the easiest method is gastrojejunectomy, which is firstly reported in our institution in 2014. But below one, the direct anastomosis, as Dr. Tokunaga he presented in the last previous presentation. This is one of the most popular method for the laparoscopic distal gastrectomy for below one anastomosis. But this technique requires very advanced cooperation skills between operator and assistants. So it may be very difficult in single incident distal gastrectomy because there is no assistant here. So I created and modified this type of anastomosis for single instant distal gastrectomy, which called as unaided delta anastomosis in single instant distal gastrectomy in 2015. There is no serious complication related anastomosis in here. So I can share the brief anastomosis technique video. First, rotated the duodenum 90 degree and transected the duodenum first. Without any assistance. And proximal stomach, draw the resection line and transect the duodenum and stomach, proximal stomach as well. This is not so difficult for transaction itself. And after that, make a hole at the duodenum. Okay. Suction of the duodenal fluid. And also make a hole at the greater curvature side of the remnant stomach. Make a hole and suction of the gastric fluids. And here's the point that for the traction, I place the traction suture at the hole of the remnant stomach without tie, just as place the suture. And pull out this thread through the umbilicus port. And grab this suture with Renia stapler at the same time in your right hand and rotate the proximal stomach like this. Because you hold the thread with stapler at the same time, the stomach is well fixed inside the Renia staple without any slippage. And also with your left hand, grab the duodenum. Do the anastomosis like this. Because you coordinate duodenum and stomach at the same time by your two hands, it's not so difficult to coordinate this type of anastomosis. Yes, and place the clip for the initial traction suture. And add one more traction suture at the greater curvature side of the anastomosis without any tie. You don't have to tie of this traction suture. And pull out this thread through the umbilicus port. Yes. And place the linear staple. Left hand handle the lesser curvature side of thread, and right hand you can handle the linear staple as well as the traction suture as well. Yeah, the end of the anastomosis. So in terms of the efficacy of the lymph node dissection, you may have a question that does this intervention helpful regarding treatment benefits? In terms of a BMI, there is a tendency of less BMI compared in single incision distal gastrectomy and multiple surgery based on the publication evidence, especially in this surgery, in this paper, BMI in single incision distal gastrectomy is significantly less than the multiple surgery. In terms of the operation time, there is no significant difference of operation time between the single incision and multiple surgery. But as you can see here, in class 1 trial, which compared the LADG and open distal gastrectomy, in this paper, LADG reported about 184 minutes for LADG, which is maybe 40 to 60 minutes shorter than this single incision distal gastrectomy. Regarding the blood loss, the two papers presented a significant less amount of blood loss in single incision gastrectomy than the multiple distal gastrectomy, and the amount of this blood loss is also very significantly less than the conventional laparoscopic assisted distal gastrectomy reported in class 1 trial. Regarding the morbidity, 8 to 20% of morbidity here, and this is which is not significantly different from that from the conventional distal gastrectomy. Regarding the length of stay, the one paper with a matched comparative study reported a significantly less length of stay compared to the conventional distal gastrectomy. Pain score is also, these two papers presented significantly less pain in single incision gastrectomy compared with the multiple distal gastrectomy. Learning curve is only one paper reported 34 cases is required to overcome the learning curve. For the survivor and recurrence, Dr. Umar reported the survivor data after the D2 lymph node dissection in 2016. In this paper, 76% of diagnosis stage 1 gastric cancer in both cases. In this paper, median follow-up is 47 months in single incision gastrectomy and 60 months in multiple gastrectomy. There is no difference of overall survivor and the recurrence-free survivor between single incision and multiple gastrectomy. However, in this paper, D2 lymph node dissection was performed for 76% of stage 1, and multiple gastrectomy was conducted in different time frame in single incision distal gastrectomy. So we have to consider that the possibility of a leading time bias confounded by the surgical skill of the operator. What about the total gastrectomy? Total gastrectomy was reported in 2014, the first time in the world. And after that, only that two paper was reported. Both of this study was the case series level. And I modified to do the single incision total gastrectomy. I modified the laparoscopic hemidouble stapling technique for the single incision total gastrectomy. And I briefly show you this clip of the single incision total gastrectomy here. I will skip the first part of surgery, which is very similar to the distal gastrectomy. Section of 11P is make an enterotomy through the anterior esophageal wall and push the ambier inside the esophagus and pierce that needle through the anterior abdominal wall, esophageal wall, and apply the linear staple to make a esophageal stump. As you can see here, there is no stent during the whole procedures. And you can see the esophageal stump here and the ligation of the remaining short gastric arteries with a top-down method. Yeah, and using the bending grasper here, which is inserted through the umbilicus at this, with this circular stapler at the same time, and do the anastomosis. And then the stump was closed with a linear staple. Also, you can do this with linear staplers as well. This is a operation of a proximal gastrectomy. Using the linear staple, transect the esophagus, and at the end of the esophagus, you can cut the esophagus. I'm sorry about this. Yeah, this is a jejunal stump. Using the linear staples, push the linear staples through the esophageal stump, and to anterior closure, I usually use the V-lock suture through a V-lock with the manual closure of the to close the anterior. Very easy to do the using the single instant gastrectomy for proximal with double track anastomosis. So in conclusion, this Singapore surgery can be considered just one step before nodes, and it may connect to between the total laparoscopic gastrectomy and node surgery. Thank you for your kind attention.
Thank you very much, Professor So. I've been informed that Professor So has to leave immediately after his talk. So if we have any questions, we will open the floor for a short time for Professor So to answer any questions.
Dr.
Okay.
Erdina, can I
Yes.
acknowledge?
Yes, who's that? Okay, let me
This
ask
is
you a
Dr.
question.
Bueno.
Okay, Dr. Bueno, good evening.
Yeah, I have a question for Professor So.
Yes.
Yeah, thank you, Professor, for your wonderful presentation. I just want to ask if you are using a 3D camera and video system in your single incision surgeries, and do you think the 3D system is a requirement in single incision gastrectomies? That's all. Thank you.
Yeah, not even for the single incision. Our institutions always use a 3D flexible laparoscopic system. For user laparoscopic system, especially for the suture of any anastomosis, 3D system may be a great advantage compared to the just 2D flexible or 2D rigid scope. Yeah.
Thank you very much.
Thank you.
Thank you. Thank you, Dr. Bueno, for your question. Any follow-up questions? Okay, that's our last question. Okay, if there are no more questions, I would like to thank Professor So for sharing your time and your knowledge with us. Thank you
Thank you very much.
Thank you, Yunsuk, for joining us.
Thank you.
Thank you. 감사합니다.
감사합니다.
감사합니다. Okay, so our final speaker is Professor Asim Shabir. Professor Shabir is a senior consultant of Division of General Surgery, Upper Gastrointestinal Surgery in the Department of Surgery at National University Hospital in Singapore. He is the director of the Center for Obesity Management and Surgery at the same hospital. He is also a senior consultant in the Division of Surgical Oncology at National University Cancer Institute, Singapore. Tonight, he will be giving a lecture on management of complications after gastric resection. Let us all welcome Professor Asim Shabir.
Hi, guys, hello. Can I share my screen or am I sharing?
Already.
Lovely.
We
Thank
can
you
see
very
you.
much.
Thank you.
Because I'm complicated, so I go last. Thank you very much, Alan. That was great of you. All right. So, the guy who presents the complication is the bad guy. So Alan chose me to be the bad guy today to make people understand that, everybody can run into trouble. I thoroughly enjoyed all the talks that were given before this. You guys did an awesome job, and thank you for making my job easy. Now, that's... So I wouldn't dwell so much into literature. I would give you a flavor of what I have experienced. As Alan said, it was supposed to be a 15-minute talk, and he himself has closed his camera. But Alan, thank you very much. That didn't sound like 15 minutes to me. So I'll probably take a little bit more than that. Anyway, post-op bleeding after GI surgery can be intraluminal or intra-abdominal, and should you follow this algorithm, it makes it very easy. If patients are stable and they have intraluminal bleeding, they deserve an endoscopy. Follow the guidelines that are there for endoscopy. Generally, patients should be with melena should be within 24 hours, the others under 4 hours. If they are stable, if they're unstable, or it's a non-luminal hemorrhage, then you can actually do a CT scan called a CT angiography. If there is no bleeding found, you can do a surveillance. If there is a bleeding found, either they go for angioembolization, if possible, like a splenic artery aneurysm, or even bleeding from a GDA. Otherwise, they go for surgery for hemostasis if they are in shock. All right. Okay, so this is one of my patients. After surgery, on the next POD, when we did the hemoglobin drop by 3 grams, we scanned and did everything, couldn't find. But 5 days later, this whole mark developed, and there was a bleeding from the trocar site that you see here. Here's a picture of an intra-abdominal hemorrhage. The patient dropped about 3 grams, and we went back in day 2 and found all these blood clots. We couldn't find the pleader. Here is a video of an post-distal subtotal gastrectomy patient. So the patient bled, we put a scope in, we couldn't clear the clots, and the patient was going in extremis. We did a CT angiogram, could not find it. So what we do is we go in, make a hole in the gastrojejunectomy, suck out the clots, and do an inspection. Anastomosis looked okay, so we closed up the gastrojejunectomy. Since this was a Roux-en-Y reconstruction, we then opened the jejunectomy of this patient, and you can see the bleeder bouncing out there right at the edge. Assuming that you do not find this bleeder, or it's just too much to ask for if you have done a hand-sewn or a stapled anastomosis, then, and you know that this is the anastomosis for sure that is bleeding, then what we recommend is you overrun the entire anastomosis with a running suture, and that will stop any bleeding from the staple line that you see. Prevention is better than cure. So at time of stapling, always look at the stapled anastomosis before you close the common enterotomies. Wound infection isn't uncommon. It is, patients present with fever, flatulence, erythema, and most of you can recognize it. The problem is that they would develop ventral hernia. Should the infection persist for long periods of time, the fascia, the midline linea alba, may not hold strong for long, and patients may develop. The recent use of modified vacuum dressings in preventing infections has been proven, as well as for those that have developed infection in enhancing wound care, keeping it moist and helping it heal. Vacuum-assisted dressing has played a great role. Here is an example of somebody who developed a complication, had basically developed an abdominal compartment syndrome, had a real local laparotomy, done kind of a damage control dressing, but we couldn't control what was coming out. Bile, everything continued to pour. Then ultimately we did a temporary closure with a vacuum dressing with a white sponge placed in between on the surface, and the peritoneum closed behind it, and we were able to get out of the abdomen nicely. Enterocutaneous fistulas from leaks like the duodenal stump are not unheard of. If they do happen, then the principles of management include improving nutrition, controlling sepsis, care of skin, use things like deoderm, which are barriers. You may even sometimes use vacuum dressings to isolate these. Skincare is of utmost importance, otherwise great excoriation and management becomes difficult. Exclude any distal obstruction, any foreign body or distal malignancy, and delay the intervention for repair of the enterocutaneous fistula as long as you can. Anastomotic leaks have been classified in various ways depending upon duration, depending on whether it's a high pressure, low pressure system. This mode of classification is largely used by the bariatric surgeons, whether the leak is intra-abdominal, thoracic, or neck, whether it was clinically apparent or it was subclinical and picked up because of other reasons. Well, the most important thing is for about leaks, be vigilant about them. Generally, symptoms are more of abdominal pain, nausea, vomiting, those related to sepsis signs. You may see either bilious or feculent or food output from the drains. Patient may go into sepsis in those cases where the leaks are in the thoracic cavity after total gastrectomies. When you do it with a distal esophagectomy, patient can present with atrial fibrillation and respiratory complications like pneumonia, collections, and effusions. Imaging is good modalities like CT scans, contrast studies, but they are not foolproof. So basically, if in doubt, then I personally prefer doing endoscopies on these patients and documenting it. It does not harm the cause. It makes you help you realize the leak earlier and institute corrective measures earlier. Recently, we've been trying to do procalcitonins to predict bacterial infection, and so far they have been good. We're looking forward to publish our outcomes on procalcitonin as well. Leaks, broadly, the surgical principles for management of leaks include broad spectrum antibiotic coverage, identification and repair of the defect where possible, or in some cases like stenting. So prevent the ongoing leak, irrigation and control of sepsis and contamination with wide drainage, and obviously enteral access for feeding where possible. If not, nutrition through a parenteral route may be preferred. So this is a GJ leak in one of our patients. So sometimes it is subtle. So this patient became tachycardic, was becoming tachypnic. CT scan just showed on day 3 something which was commensurate with what they call as post-operative changes, but the patient wasn't really looking good. So one of the investigations that we use is bringing them for diagnostic laparoscopy. At first diagnostic laparoscopy, you can't really see much there. There was just a little bit of fibrin, which is quite normal, but no definite signs of leak. So when we blew air through it, you can see that the gastrojejunectomy has actually leaked in this patient. There was a pinpoint hole, which on endoscopy bubbled water, and we just did an overrunning. And after 5 days, the patient was on his way home with liquid diet on board. So you can not only prevent a major disaster by diagnosing them early, but you can also shorten their length of stay and hopefully decrease morbidity over long periods of time. Duodenal stump blowout or duodenal stump leak is also another stressful complication. It generally follows the Billroth-2 anastomosis. The incidence reported in literature is about 3 to 5%, and the causes, which are very eluding and one should take care of them, are extensive dissection leading to compromised blood supply of the stump. We tend to try and push burying that duodenal stump, that staple line, but if you overzealously overdo it, it results in ischemia, and that too can result in blowout. I've had a couple of duodenal leaks in my career, and one of them I put these hemolocks to secure a bleeder right at the top of the staple line, and that it leaked from that area. In another instance, I overzealously sewed, and that resulted in a duodenal stump leak. One of the rare causes is an afferent loop obstruction. The afferent loop is the biliopancreatic loop, and if that gets obstructed, then the pressure built in the loop can result in a duodenal blowout. So address the underlying cause, provide nutrition and sepsis control as we would do for any other pathology. If you have a duodenal stump leak, can you feed via NJ tube? Yes, certainly you can, after sepsis is controlled to a certain extent. In some people, it may be fulminant sepsis requiring laparotomy, in which case wide drainage is the answer. It takes generally about somewhere close to 6 weeks to 3 months for a controlled fistula to form before it starts closing itself. You can do an endoscopic management for leaks in upper GI surgery, early stenting. You can cover the hole. You really need a fully covered stent capable of conforming to the shape of the leak site. So most stents, as you would note, are actually straight stents. And if you put them around the curved structure of a stomach, they tend to recoil back into the shape, and thus erosions are not uncommon, especially when you put them in the stomach side. Secondly, the stents need to anchor somewhere. Even in esophagus, they might tend to erode. So ongoing leak, which is a parastent leak. So sometimes around the stent, there would be space and they will continue to leak from there. Erosions, migrations, and the formation of thick fibrotic tissues are some of the complications. This is one of my patients who has basically an esophagojejunostomy after a total gastrectomy. This is the blind ending stump of jejunum. This is the afferent limb going down, and this is the leak area that you can see this. So the anastomosis posteriorly had given way. A contrast study showing extravasation of contrast clearly, and that you can see is linked to the drain. So the drain is draining the contrast well. We went in, you mark the proximal extent, as you can see here, and you mark distal markers with radiopaque markers on endoscopy. You can use lipoidal or contrast material, and then you put a wire through it. Here you can see a wire and then seeing a stent, long stent being deployed. Once the stent is deployed, after about 2 weeks we did this, you can see that the stent tends to embed itself, especially if the crown of the stent is not covered. Through the stent, we put a guide wire after the stent had expanded after a couple of days, and we put in a feeding tube, and we started feeding the patient through a nasojejunal feeding. The benefits of enteral feeding over parenteral feeding are well known, and we do not need to revisit those at this forum. We did to make sure that the stent was completely occluding the lumen and there was no ongoing leak, so that the patient could have some comfort sips of water. We did a study after inserting the tube, and you can see that there is complete occlusion with no leak on the outside. After 6 weeks of management, the area has largely healed, and we took out the stent. There are newer players in this field. If you pick up the leaks early, you can use what is in the center. These are the Ovasco clips. These are literally like deer traps or mouse traps, and you can get in and actually pull in large amounts of tissues and can bite full thickness bites. But generally, I find them difficult to use because by the time we discover the leaks, it's day 3, day 4, and you intervene, the tissues are quite hard and they may not really hold, or you may not be able to oppose tissues nicely. But if you can, this is one of it. If the leaks are well established, then there are things like lumen opposing stents, where you can actually drain the abscess into the stomach, or you can use double lumen pigtails to drain abscesses into remnant stomach or even esophagus. What is current is the use of endosponge. So basically a suction tube is passed through the nose. It's connected to a sponge, which is then put down into the cavity to suck. And this is the case of an esophagus. If you have done a total gastrectomy and it kind of leaks into the mediastinum or pleural cavity, this is one of the options that you may exercise and drain the area. Pancreatic leaks, rare, fortunately, but when they happen, they can be quite disastrous. Apart from causing pancreatitis, overzealous dissection or over the adventitia of various vessels to harvest lymph nodes, especially taking away the plane which carries the nerves, results in aneurysm, and so does pancreatitis. And we can lose a patient from a major bleed, especially the splenic artery bleed. If you have a Herald bleed, always think about an aneurysmal vessel. And the case here is of one that you can see. I've taken this off the web. This is not a patient of mine. And you can see a splenic artery aneurysm here, and it can be coiled by the radiologist, and you can solve the problem effectively. Chyle leak, very rare. In total gastrectomies with distal esophagectomies, there is always a possibility. I find that in my gastric cancer patients, the station 8 lymph node actually has quite a significant size lymphatic drainage. And if you do not, initially I used to just take it with an energy device, and I would seldom get a leak of chyle from from that vessel. I have not had to intervene, but what I tend to do is convert them to medium chain fatty acids, keep the drain in there, and as the nutrition of the patient improves, they generally tend to, because they're low pressure, they would seal off. If it doesn't seal off, then options like radiotherapy, which is rarely exercised, or even going in again, finding the leak after feeding a high-fat diet, you can underrun the leak. This protocol is for chylothorax leaks, and they go by volume. And you see there is reoperation, low fat, total parenteral nutrition, and gradual shift to normal diet if the leakage is minimal. Stomal stenosis in cancer surgery can be due to recurrence of cancer, otherwise ischemia, tension, the use of small circular stapler, especially if you use for your gastrojejunostomy or esophagojejunostomy, a 21 circular stapler, it can result in higher rates of stenosis. Endoscopy is not the best modality to find out a stenosis. Probably a contrast study is better, because when you do endoscopy, it results in expansion, and it may take away the kink. It may take away the stenosis to a certain degree, and when air passes through, you're convinced and you tend to rely yourself and say, well, there is no stenosis, I've tried and done everything. I think a better information is obtained from upper GI series. Treatment will involve endoscopic balloon dilatation, rarely revision surgery, or even conversion to other forms of bypasses. Like in case of a Billroth-2, if your efferent limb is obstructed, you may even want to convert it to an omega loop. Well, I apologize, there is a name. So this is a EJ stenosis that you can see here, and we went in. You can see after dilating it to about 16 French, we then put a stent through, and the patient left the stent there for 4 weeks, and the patient recovered well and did not re-stenose. So use of sometimes use of steroid injections and sometimes stents after dilatation may give you better outcomes. If stents, if we need to do, sometimes we need to convert, as I said, from Billroth to omega, revise the gastrojejunostomy, do a completion gastrostomy, and obviously There's always, if the patient is not like you do, let's say there's a recurrence of a cancer and you have an opportunity, you can always use these lumen opposing stents to create another anastomosis with a loop of bowel just to bypass that loop of bowel. And we have done that effectively in our own unit as well. Internal hernia, with many of us now going and doing more and more laparoscopic gastric cancer surgeries, subtotal gastrectomies. With laparoscopic surgery, intra-abdominal adhesions are far less. And internal hernias are not uncommon if you do not close. A rate quoted about 6% in bariatric literature is what I know of, but increasingly reported in gastric cancer surgery. So I close all my defects for these hernias. Classical sign of a switch roll sign here, swirl sign here. And you can see this is a Peterson defect from a Roux-en-Y reconstruction that you can see. Although I closed it, but it somehow opened up. And you can see that the entire, this is duodenum, this is the Roux limb going up, that's the transverse colon, and that's the defect, that's the Peterson defect. So we had to redo the closure. And you can see that you've got to stitch the mesentery of the small bowel to the mesocolon of the transverse colon to close that potential defect. And then you suture up and it's early. It's good to realize it early because if herniated bowels go through there, it may result in strangulation in these patients. Very, very rare. We've seen a couple, but not very many marginal ulcers. If you leave a bigger gastric stump behind, it can result in marginal ulcer. Also, if you operate on morbidly obese patients who have gastric cancers and do a gastrectomy, sometimes because of tension, staples, NSAID use, Helicobacter pylori infection, and smoking, you can get marginal ulcers. These ulcers are invariably towards the jejunal side and occur on the jejunal mucosa. Treat them conservatively with PPI, treat the HP infection, remove all insulting factors like smoking. If everything fails, they perforate or they bleed and they start becoming complicated or become non-healing despite best medical therapy, then surgical revision of the anastomosis with conversion to a hands-on anastomosis is advisable. Another rare entity to see, efferent loop syndrome, is due to partial obstruction of the efferent loop, especially if you fire a stapler from that direction and you close the common staple wound by suturing, you may narrow that, and it's usually seen in Billroth 2 anastomosis. Most of the time the treatment is surgical, and what you do is you do a side-to-side anastomosis. It can result in bacterial overgrowth and blowout of duodenal stump as well. So generally patients present with abdominal pain. So if you've done a Billroth 2, your options, if the patient develops, is to convert an efferent loop syndrome, is to convert to a Roux-en-Y. You can convert to a Roux-en-Y, or you can convert to normal anatomy in this fashion. And I prefer to connect them in an omega fashion, which is a much more simpler operation rather than going into more complex surgeries when they're not very well. Nutritional derangements are something that happen in the long term. Because this was a talk on surgical complications, I did not intentionally deal with it. However, it's good to know that even after leaving a significant portion of stomach, patients can develop protein energy malnutrition. The most common nutritional deficiencies after any form of gastrectomy, be they subtotal or total, are iron deficiencies, B12 deficiencies, and vitamin D deficiencies. Your patients who have total gastrectomy should always have B12s on regular intervals, and iron if needed, especially women of childbearing age, and you should regularly survey for these deficiencies. I don't have time and the bandwidth to cover motility disorders, but I just put down there things like constipation, loose stool, post-vagotomy diarrhea, dumping syndrome, and gastroparesis. Last but not the least, I would like to invite you to join us on the 11th and 12th of September for the ELSA 2020 Virtual Congress, MIS in the Era of Disruption. With that, I'd like to thank everybody for your kind listening, and we can go on to take questions. Thank you.
Thank you. Thank you very much, Professor, for that very interesting topic. So now we open the floor for any questions. If you have any questions, just type them in the Q&A box. Okay, let's start with there was one question posted in the box. It was posted specifically to Professor Long, but I'd like to open it to the rest of the lecturers. There's a question from to Professor Long. After proximal gastrectomy, is it necessary to do a pyloromyotomy? Okay, so yeah, Professor Long has answered it. Not necessary. Are all of the other speakers in agreement? You don't do pyloromyotomy anymore? Anyone can answer.
I don't do pyloromyotomies anymore, but pyloromyotomies do not prevent a leak. If you don't do them, they make your leak worse. That's it. So if you get into trouble, then it's more trouble, but that's about it.
Okay.
Yes, I can explain something. Because you see, after for proximal gastrectomy, also for esophagectomy, and I reply by gastric conduit, it's not necessary to do by pylorostomy. We can dilate by a finger. We use finger to dilate the pylorus also. And we have no case for gastric dilate. We have another case. No problem to do the pylorostomy.
No problem. Okay, thank you. Right. Since there are no questions yet, I'd like to ask. Since we're on the topic of the proximal gastrectomy, right now I don't know what should I do if I do a proximal gastrectomy. Should I do a kamikawa, or should I do a double track? What do you think? Anyone can answer, Professor Long or Professor Tokunaga or anyone. If I do a proximal, what should I do now?
Hello?
Okay, yeah.
Okay, I think it's a length of esophageal invasion. I think the patient doesn't have esophageal invasion and we can preserve more than 2/3 of the stomach. I think first choice should be Kamikawa method. On the other hand, if the esophageal invasion length is 1 centimeter or more, or the size of remnant stomach is less than 2/3, I prefer to perform double tract reconstruction.
Right. Okay. Yes. So more of the tension. Huh?
Yes.
Would you like to add anything?
The size of the stomach.
Yes.
I think from the viewpoint of the QOL, Kamikawa method should be the first choice. But if the size of remnant stomach is too small, it's not so effective. So in such case, I will prefer a double tract or jejunal interposition.
It's largely a technical issue and an assessment issue that you need to go through, right? So if you're going to do a proximal gastrectomy, but you're going to do, as Professor rightly mentioned, if you're going to go into the thorax and finish your anastomosis, then you can even do a thoracic Kamigawa if you can. But if you want to stay in the abdomen and finish your operation, then a double track reconstruction is the safer option because you can finish it. You can suture and get your way out. In the thorax, doing a Kamigawa is not that easy. I've done one. We've published it, but I think it's quite nerve-wracking. So I think that's probably the one and only one I would ever do. So
yes, I agree. Yes, the thoracic Kamigawa is possible, but we need space. So technically demanding. Yes, it depends on your policy, which do you prefer. Okay, thank you very much.
Thank you very much, Professor. Okay, are there any more questions? we had 130 participants earlier. So no questions means you taught them well. To all of our guests.
There's a question for Shannon from
Okay.
Arlene. Why don't you ask the question?
Hi, sir. Good evening, everyone. Hi, Dr. Shannon Chan. I'd
Hi,
like to
Arlene.
ask if, in your experience, hi, sorry. I think in your experience, do you routinely do EUS for your patients prior to scheduling them for cells?
Yes, we all do LEX because we want to assess, we do an OGD to assess the luminal component, and we do an EOS to assess the extraluminal component. So we can have a better guess whether we should go for a CleanNet or to go for a NEWS before the surgery, because the equipment we need is a bit different.
Okay, thank you.
There's a question from
There's a
Tom.
question.
Yeah.
Yes,
Sorry,
there's a
Emong, can
question.
I just
sorry. Follow up.
sorry,
Dr.
Emong, a follow-up
Sarmiento?
question to Shannon.
Yes, sir.
Shannon, good evening.
Hi, good evening, Ray.
Hi. So you mentioned with regards to the EFTR, and it's a combined laparoscopic. The full thickness is done endoscopic, and the closure is laparoscopic. Can you expound on this a little bit, and then any experience on primary closure using purely endoscopic techniques? And also, do you think it would be feasible to do EFTR, go into the peritoneal cavity, and then do the sentinel lymph node biopsy without actually cleaning up the basin, because we know it's very difficult to do it endoscopically. Just get the lymph node that has color or signal or that lights up in ICG, and then close the defect primarily using endoscopic techniques.
Okay, thank you, Ray. So you had two questions. So first question was, do we close, if we do EFTR, do we close it luminally with an endoscopic method? So this is our routine approach. So it is, if we plan for EFTR, it is uncommon that we need to use laparoscopy to close it. So we usually are able to manage to close it endoscopically with either just with clips or with the loop clip method that I've mentioned with the detachable snare. The trick with the EFTR, actually the most difficult part of the EFTR is not to lose the specimen to the peritoneal cavity. Because when you do the endoscopic full thickness approach, with the last bit that you leave, it may fall outside, and it will be disastrous because it would almost be impossible to find it with even if you put the endoscope out into the peritoneal cavity. So we've had it once, and it was a very horrible experience. So we try to leave a very small part and make sure that we flip the specimen back into the peritoneal cavity, and we close it. So closing usually is not a very big problem. Especially for lesions which are 3 centimeters or below. As for your suggestion of using the completely nodes approach for the sentinel lymph node, the problem is with the scope, because even if you use if you inject ICG and technium, the OGD doesn't have the near infrared sensor to see the ICG, and we don't have the isotope probe for OGD. So you will not be able to see the sentinel lymph node with this method. Of course, we await for the new scope, so maybe you can develop a new endoscope that we can do this with the ICG.
Shannon, any experience with Apollo EndoStitch to close up this?
Yes, we also do have the overstitch. There's actually a new scope that is now marketing with much that you can mount it on a normal endoscope. So the old one, you need to mount it on a 2T scope, but the new one is actually quite difficult to use. So we still use the 2T scope Apollo overstitch, and it's actually easier than you think. With you can use a singe to draw the edge of the mucosa towards yourself so you can take a full thickness bite. So it's actually not difficult to use. But if you use this, it usually needs time. And so the patient has to be under general anesthesia, and the peritoneal cavity has to be decompressed at the same time.
Okay, thank you.
Hello.
Yes.
Hi, Shannon, can I have another question? Because if you do your EFTR and then you do your lymph node dissection, how do you maintain the insufflation inside your stomach or inside the intraperitoneal space if you do the EFTR?
You have to do it step by step, so it will be difficult to do it at the same time because, as you mentioned, it's difficult to blow air on both lumens, the stomach and the laparoscopy. So you have to do it by stage. So first the EFTR and then the laparoscopic approach.
Okay, thank you.
Okay, Arlene. Okay, thank you for your question.
So
We
I
have
have a
question in
question
the...
for other panelists.
Yeah, okay.
For exactly what indication you do for proximal gastrectomy, because for us, we do routinely for GIST that we're not able to remove with the combined technique, or for T1 SM tumors. Do other panelists have other inclusion criteria for doing proximal gastrectomy for gastric cancers?
Proximal.
Yes, for us, because in the past periods, I choose the case with the T1 and a euro. But now I open the T2, but especially having an euro. Especially interpret you to for biopsy, lymph node group 6 and group 4D. It's very important. Because if you have the lymph node group body, sometimes it's a positive. You could convert to the total gastrectomy.
But the key is how to do an accurate staging preoperatively. So sometimes it's difficult to tell whether the tumor is, T1 SM, T2, or sometimes accidentally it comes back to be T3. So how do you accurately stage it before the surgery?
For me, I do the abdominal CT scan. CT scan.
Okay.
Yes, I think you can I think that you can realize on the diameter of the tumor. The tumor more than 2 cm. I think that sometimes first in Vietnam we have no US in my we have no US, so sometimes difficult for me to know exactly the stage of treatment. Experience about the tumor diameter of the tumor more than 2 cm, and on CT scan sometimes more than 2.
Shannon, I've done them in locally advanced cancers as well. So T3s. This is by no means the standard of care. This is beyond criteria. And I only do them when I can actually dissect, and if they're on the greater curve, I can do the station 10 lymph node dissection safely and effectively. Then I do them because both the Japanese and the Korean data shows that even in locally advanced, the risk of metastasis to station 5 and station 6 is less than 4% or so. Right. So if they are not so high, I still do them. I have done them, but I choose my patients. Generally, they're elderly, they've crossed their 70s, and then they have comorbidities. You just want to give them a good, nice life. Whether you do a much more radical one, will it really improve their survival when they're going to go for chemo? May or may not, because I think just yesterday or day before yesterday, the Korean trial for locally advanced cancer laparoscopic surgery actually came out. The publication just came out and shows no difference, same survivals. But that is for distal cancers, not proximal cancers yet. I think there is a trial that's going on for proximal cancers locally advanced, and I'm sure it will not show any difference. As long as you can maintain the sanity of surgery, don't hook around, play around with the tumor, and don't undermine the lymph nodes and everything, I think you should be all right. But that's my personal do, and I do not recommend it as a standard of care.
Yes, I want to hear the opinion from Professor Masaroni.
Yes, hello.
Yeah, from the Japan, the opinion. Yeah.
Hello. Actually, early gastric cancer located upper third of the stomach is a definite indication for proximal gastrectomy. But in our practice, we also perform proximal gastrectomy for severe type 2 esophageal junction cancer. Actually, as Professor mentioned, the incidence of number 5 and 6 lymph node metastasis from upper third advanced gastric cancer is very low. But that of severe type 2 advanced gastric cancer is much less, much lower. So I think it's neglectable. So many Japanese surgeons these days prefer to perform proximal gastrectomy for severe type 2 advanced gastric cancer.
Yeah.
And then you will perform the Kamikawa reconstruction after, because for severe 2, we expect the esophageal transection line to be quite high.
Yeah. Some perform Kamikawa, but in my case, I'm not confident in my procedure to perform Kamikawa in such high esophageal transection line. So in my case, I perform double tract reconstruction in case of proximal gastrectomy for severe type 2 AG.
I saw some videos, some Japanese videos where they, for high anastomosis like this, where they perform Kamikawa, they insert an extra port in the left lung for better visualization. So they call it the left lung thoracoscopy assisted high anastomosis approach, something like this, which was quite interesting to see.
Yes, interesting, but I've never experienced complicated procedure. In the future, maybe I will try. But so far, I prefer double tract reconstruction.
So in your experience with the Kamikawa reconstruction, is there a certain rate of stricture or stenosis?
Actually, I've done less than 20 cases. And honestly, first initial 5 cases, I had so many stricture. So I don't know why that was, but this case later 5 cases no stricture, and the initial case maybe a problem. Maybe I think the procedure is a bit tricky, so I might have stitched too tightly.
So is there any particular technique you would recommend to avoid stenosis in this complicated anastomosis?
These days some Japanese surgeons reported the stricture and the association between stricture and the diameter of the esophagus. So if the diameter of the esophagus is too small, they recommend to perform double tract, not Kamikawa. So the diameter of the esophagus may affect the incidence of post-operative stricture. And as a technique, I recommend to stitch very not too much tight. But of course, if we stitch very loosely, we might have to worry about leakage or something. So it's balance.
So may I also ask other panelists your opinion on the benefits of proximal gastrectomy versus total gastrectomy? Because before, reports has been the postulated benefits are for the vitamin B12 anemia, better functional outcome. But it seems that with the publications available, it seems the most recent data does not show an obvious benefit of a proximal gastrectomy versus a total gastrectomy in terms of functional outcome. So what is your opinion? Because before, the stats are very convincing that the albumins are better, the anemia is better, but it seems that the recent data kind of overrides the old data on the benefits.
I'm not sure if there is a randomized control trial that really looks at quality of life and really looks at these in a randomized fashion. Having said all that, whenever you will bypass the first 50 centimeters of jejunum, no matter where you do it, in bariatric surgery or anywhere, you will get nutritional deficiencies. So you will get iron B12 deficiencies, that's having said. I feel that my patients eat better, complain less, their runway to recovery, they don't lose that 15 to 20% of body weight that they would lose with a total gastrectomy, and the quality of life in terms of eating is better. And 2 pathways for food to pass is better than 1. In case one gets blocked, the other one is open. That's just about, but that's just about a joke. But no, yeah, quality of life, perceived quality of life is better.
Okay, so have you actually done contrast studies on your post-op patients? Because we've done routine contrast studies in our double-tracked after proximal gastric, and it seems that most of them all just go through the jejunal limb. So it's definitely not a 50-50. So it's more like an 80% go through this jejunal limb and 20% go through the stomach. And because the stomach has stasis itself, so if you wait long enough, the contrast actually, most of it goes back into the jejunal limb for drainage. So I'm really not very sure that the functional outcome would be very much different from my.
So I don't have that big series to answer that question, but what I've noted from my anecdotal is that if your loop of jejunum stays behind your stomach when you do your anastomosis, it will preferentially empty into the afferent limb. That's the jejunal limb, right? If you do the anastomosis on the anterior surface of the stomach, it will preferentially empty into stomach. Yeah, so it's how you do your anastomosis and where you do your anastomosis that gives you that difference. So if the anastomosis is on the anterior end, it tends, and it's wide anastomosis, it would dump into stomach. But if you create a narrow anastomosis and it's more posterior, it will tend to go down the jejunal limb.
Yeah, probably that makes sense.
Thank you. Professor Long, do you have anything to add to the discussion?
No.
Okay. There's a question in the, yeah, sorry.
Sorry,
there's a question in the, yes, doctor, yeah.
Sure. I'll ask a question after you posting that question.
Yeah, just one question for Professor Tokunaga. What is your experience or opinion regarding the uncut Roux-en-Y reconstruction as routine following total or subtotal gastrectomy? Okay. So uncut Roux-en-Y.
Actually, I don't recommend uncut Roux-en-Y. Maybe 10 years or more years ago, Professor Uyama from Fujita Medical University recommended this method. But 5 or more years later, he reported the problem is recanalization of the uncut Roux-en-Y limb. And it's just closure with stapler. And several years ago, its patency, it became patent. And so in the long run, uncut Roux-en-Y is not effective, he reported. So these days, I think few Japanese surgeons perform Roux-en-Y, uncut Roux-en-Y, and I've never performed uncut Roux-en-Y reconstruction.
How about the other, maybe our other panelists can also answer the question, yes?
So I do it. I've done it. Well, it's another Billrod too. Just add a little of exclusion of bile and you may get away with it, but you may not get away with it. As Professor rightly mentioned, Professor Masanori rightly mentioned that if the staples may eventually open up, and the recanalization will result in the bile going back, well, still worth a try. No harm. Um, really, you're talking about benefits and pros and cons, you know, and these are things without randomized control trials we would never be able to prove. Right. So yeah, you can say, well, because Roux-en-Y came first, that was the gold standard. I don't think I will ever have numbers to compare Roux-en-Y versus an uncut one. So I guess the Japanese or the Koreans can do that, and they probably will do it in the near future. But yeah, some patients just don't want. They say, you don't cut like this. Can you do something like this? Well, okay, fine. I'll do an uncut Roux-en-Y. At least I can save you some bile going in. Having some knowledge from bariatric surgery, what we have learned is that bile in the stomach is not harmful. All right? Bile that goes beyond the gastroesophageal junction is harmful. So bile in esophagus gives you adenocarcinoma of esophagus. Bile in stomach does not give you, and there is loads and loads of literature out there to speak about it. Does it give you gastritis? We did a randomized control trial comparing Roux-en-Y versus Billrot 2. Not very much different. If you tell me, I can give you examples from bariatric surgery where a 100-centimeter elementary lip has bile reflux. So, you know, how big a alien can you make? So we can go on arguing about these things, but yes, safety of patient, needs of patient, and if really somebody can prove a benefit, makes sense.
Thank you.
Yes, these days, period 2 reconstruction is more frequently performed in Japan. As you said, now we know by reflex, the stomach is not a matter, and it's not carcinogenic. It cannot cause carcinogenesis. But I think probable benefit of uncut Roux-en-Y is it may prevent post-operative Roux-en-Y stasis, delayed gastric emptying, but we don't have any data. So, and also it's difficult to perform randomized control trial. So I think no one can answer this question. Just from our personal experience, not from large clinical trials. Thank you very much.
Dr. Sarmiento had a question.
Thank you, Emma. I'd like to pose a question to Asim and probably Shannon. Asim, good evening. So I'd like to ask with regards to your, experience with leaks, between choosing between stenting the leak plus a percutaneous drainage versus an internal endoscopic internal drainage or an endoscopic sponge or vacuum drainage. Which would you choose? I mean, what are the situations wherein you would choose an endosponge vacutainer drainage versus a stenting plus a percutaneous drainage? Because by experience, I do agree with you. All these the tissues around a leak area, especially when it's acute, the Ovesco won't really hold, or the Ovesco won't actually be able to close it.
Thanks, Ray, for that question. Endosponge I will use for esophageal anastomosis leaks if they are in mediastinum. I will not put them down in the belly. And the problem is because every 3 days you need to take it out, and there are no ready-made available devices that you can put. You have to custom it, pull it through the mouth. Patient has to go through GA. You got to pull it down, push it down. That's a lot of ask from a patient. Yeah, so very high risk. If you're going to develop bad mediastinitis and you have really no choice, I would endosponge it. If the leak is very tiny and I can just control it by a drainage, I would get a percutaneous drainage and drain it. But if it is sizable and I see that it's going to need time, and I'm talking about esophagojejunostomies, I would stent it for 2 to 4 weeks. Depending, but I will survey it every 2 weeks to make sure the stent doesn't erode, because stent erosion in small bowel is much more quicker than stomach. So I'm very wary of those ones. The gastrojejunostomies, I don't stent them. I just drain them or I operate on them, reoperate on them. Sharon, if you have anything different.
For us, we're more pro endosponge because we've had quite a few complications from stent-related complications, as you've mentioned, perforations, bleeding, some stent migrations, which are often very difficult to deal with. And I think one of the more important things is if you have a cavity to drain that is not drainable with a percutaneous approach, you can always put an endosponge in the cavity for suction purposes. So this is one of the good things of endosponge, because a stent will not be able to deal with a cavity outside the lumen. We've done a hybrid approach, so the cavity drained by the endosponge and the lumen we put in a stent, but it was very difficult to manage, a bit complicated. So our usual practice, if post-esophagectomy leak, it's almost always an endosponge. For total gastrectomy, if it is just a small leak, we just close it with Ovesco or metal clips. And a bigger one, we usually put in an endosponge. And actually, it's interesting, the ISD tumor board last week or 2 weeks ago, they actually mentioned that if you, for the first few times, you need to change it every 3 to 5 days. And after you stabilize, you only need to change it weekly. So it was a very important tip. So one of our patients in the ward, we've decided we're going to do it weekly from the tumor board meeting from that time. So we'll see how it goes, because 3 to 5 days is definitely quite labor intensive and difficult for the patient too. So I guess you have to tailor make to each condition and the patient to decide which is best for them.
So we have, on the contrary, also done, if in the mediastinum, like after total gastrectomy with a distal esophagectomy, if you have a leak with a collection in the mediastinum, what we've tried is basically do a double pigtail. If the cavity is mature, if it's nicely secured, you can put a pigtail into the cavity and pass it into the remaining stomach, if it's the proximal, or into the jejunum, and the cavity will drain automatically in there. And that kind of gives it a nice chance to heal as well.
Thank you. Okay. Any more questions, please? So, okay.
I think I want to. It's more than 3 hours we've been going.
Right.
Okay. But it's a very interesting topic, and we have such, a very nice evening, nice discussion with all the experts. We've learned a lot from all the experts. I think we need to end the webinar. This is the last of the 4 weeks of the gastric series. Anyway, Emong, let's wrap it up.
Okay. Yeah, I'm gonna pass it back to Doctor. Actually, to you, Doctor. So,
actually,
to thank all of.
We would like to thank, of course, the gastric group from Ronsong Ang, Emong, Orlina, and of course, Duday Navarro for a very nice program for the four weeks that we had. This last episode is actually quite interesting. We had quite interesting and too tiring too. We have 5 speakers, 5 experts who really talk about very interesting topics, and we learned a lot from all of them. So I would like to thank all of you for joining us and sharing your expertise to us and your time.
Thank you.
It's quite,
Thank you.
Thank you so much. I hope we can invite you again. We promise not to take too much of your time. Also,
We hope to come in person this time.
we really put everything in for the last series, because it's quite, it's the last. We have 4 series for gastric surgery. So we've covered up everything about gastric cancer, benign gastric, and everything about gastric actually. So anyway, we would like to thank everyone. Before we close, I would like again to call my 3 bosses. I have 3 bosses. Ray Sarmiento from Rizal. Ray.
No, Alan is actually my boss. He's my senior. So, as Professor Sabir, Shannon, the rest of the guys, thank you for actually joining us. It's been a wonderful night and a very useful night, or a night full of new things for us to consider when it comes to treating our gastric cancer patient and even the complications that we encounter. So thank you very much. Um, I'll pass the mic to Dr. Marines and Dr. Abali for some few words before we close the session. Thank you
Yeah.
very much. Thank you very much.
Yeah,
everyone.
again, thank you to the 5 experts for sharing their knowledge. I think everybody will agree that we learned a lot this evening. And I wish again to thank Allen and the Gastric team for putting up a very nice lecture series. So again, thank you, good night, and be safe, everyone.
Thank you. Thank you very much for having me.
Dr. Abadi?
Yeah. Thank you again, no? Especially to the gastric panel. It was really a successful one. And yeah, I would like also to thank the different foreign speakers for sharing their expertise. We really learned a lot, and we are really rethinking about the new trends in the treatment of gastric CA. And yeah, Alan, congratulations. You did a lot with this UMIST. So good night, everybody, and thank you. Thank you. This is a very good lecture series regarding gastric.
Thank you.
So with that, thank you again to the panelists. Thank you, Alan, and back to you.
Thank you, boss. Asim, thank you. Shannon, thank you.
Thank you.
Prof. Masanori,
Thank you.
so much. Of course, you would like to thank Bernice, Ronson, and Emong. I would like to say thank you also to John Andrew Bueno, Dr. Bueno. Thank you for joining us. I think Simon just left. I don't know where Simon is. Anyway,
Dr.
thank you to
Rogelio,
the whole
thank you
team,
very much.
UMIST team, for making this possible. Thank you.
Thank you.
Shannon, Asim, Prof. Masanori, we can have dinner now.
Thank you.
Next time, we need to have a face-to-face meeting.
Yes,
okay,
of
next
course.
time. Hope to see.
Thank you. Thank you.
Thank
It
you.
has to have beer around it.
Okay, good night.
Good night.
Sir, good night.
Good night.
Shannon, good night. Thank you
Thank
very much,
you.
Shannon.
Bye.
Good night, everybody. Thank you.
Asim, thank
Asim,
you.
good night. Thank you very much.
Asim, I think next week or next month would be, no, the month after would be the
Bariatrics.
bariatric. We're preparing the bariatrics. I think. So you'll. Why are you hiding? I can still see your head, Asim.
You only see a header now, Bor.
We will be doing the bariatric